our guests join us. Dr. Overtveit, will you be able to join us by video?
Yes, yes, I can. Can you hear me? I've got my video disconnected, so I can join any time.
Okay, go ahead and join if you would, John. And
well,
I'll
someone
just say,
needs to let me in, I believe.
Tech staff needs to help you. I don't know how to, I'm not familiar with that setting.
All right, thanks, but I'll wait.
It was great to have you with us on our leadership call.
Thank you. It was a very interesting catch-up.
So Jenny Wu is our star lead pre-med student assistant. She's got great Zoom skills and can help you, John. So why don't you two email each other in the background, and hopefully she'll be able to help you get on video. So with that, I'll just say next slide, please. Most of you already know me. I am thrilled to welcome you to our first University of Best Practices of 2022. It happens to be our 297th University of Best Practices. We've all been aging together in this over more than a decade of work across the state in multiple University of Best Practices. We have built 4 of them with the help of all of you. Our mothership is UC Berkeley School of Public Health, Center for Health Outcomes and Innovation Research. We've been collaborating with the California Department of Public Health since really going back to 2007 when this was really launching from my desk at the Department of Managed Healthcare. We have wonderful support from Blue Shield of California, the Stroke Awareness Foundation, the Tennis Getter Foundation, Los Angeles Public Health, the California chapter of the American College of Cardiology, the amazing academic medical centers from across California, including the University of Southern California that is hosting our continuing medical education today. Stanford and the various UCs are all involved as well. And we are so grateful to our biopharmaceutical industry's support, not only for the Right Care Initiative, but through the pandemic. Where would we be without them? So I just want to say that we're also grateful to the Health Trust of Santa Clara County that funds our work with the Community Health Partnership Community Clinics of Santa Clara County. Please keep an eye on the chat and chat your questions to our speakers as we go along. Next slide, please. We compete against disease and not each other in the Right Care Initiative, and that's what makes us strong. And that's what's kept us building a stronger and stronger community through the pandemic. I believe that we have created quite a support system for those of you who are at the front lines battling this, fourth wave of the pandemic. We have over 180 people signed up for today, and we are so grateful to our amazing leaders and speakers for being with us. I want to mention that although you don't see John Overtveit by video yet, he has come to California to visit and get out of the cold. He continues to help manage the COVID crisis in Sweden from his Southern California digs, and we're thrilled that he's back with us. I'm sorry, John, we couldn't see each other in person this time. We also have with us from the United Arab Emirates, Jean Shadadpouri, who is the former Vice President for Medical Affairs for HealthNet, and who now has taken on a new business role internationally. Next slide, please. So all of you who've been with us over the decades know that our goals are really to prevent preventable disability and death. And we focus on 3 measurable and critical biometrics: LDL 100 cholesterol, blood pressure 140/90. Of course, we'd rather that was 120/80, along with A1C less than 8. So we have started 4 university best practices across the state, and we run 2 sessions virtually a month now. We also have our initial pilot community today meeting at the very same time on another critical topic that we've been working with them on. Next slide, please. So it's a wonderful day where we have built through the pandemic stronger collaborations across the state and even across the country and internationally. So we do have with us today the National Heart, Lung, and Blood Institute and multiple state and federal agencies, as well as other states. And with that, I think I'm going to give it to you, Bill, because I've got some background noise.
All right, I am going to put up some slides here and start a broadcast, and just let me know if you are able to see my first slide.
So Bill, please introduce yourself because I've got background noise.
Right, but all right, do you see the first slide?
Yes.
Yes, indeed.
Great, great, great. Okay, I'm Dr. Baumer, and I'm the statewide chairman for Right Care Initiative, and I am also at UC Davis and some other areas that I work with and organizations as well. We want to welcome everyone today for the program, which I think is going to be a very exciting program that we're going to present today, and we have great speakers. We wanted to review for a few minutes something about COVID. Now, I know you're sick and tired of COVID and all of the restrictions and hearing about it, but the reality is we have to learn to live with this virus, and that's what we're going to discuss today. The virus, as we know, is winning the contest right now. COVID, as you know, gives multiple symptoms shown here, and each of the variants that we've looked at has a little different play on some of the, in fact, symptoms that we see on the left, as well as a little different involvement in all of the organ systems that we see on the right. And COVID can affect every organ that we know in the body, with symptoms and morbidity with it, as well as mortality. At the bottom, we can see we have over 830,000 deaths in the US, almost inconceivable 2 years ago that we could have this many deaths from this particular virus. The acute infection seen on the left has various manifestations, from critical conditions on ventilators all the way up to having mild or no symptoms at all. Infection lasts 2 to 3 weeks at that point, but after a period of 3 or 4 weeks, it can progress in a number of individuals, and it's not small, maybe 10%, maybe 15% of individuals will develop post-acute COVID with persistent symptoms that we have a clinic for that has lasted at least 18 months. So we don't know if these are going to be indefinite or merely last a couple of years in those individuals. The interesting thing about COVID is it's extremely complex in its interaction with the body, because the virus requires our body cells to manufacture all of the proteins needed in the virus in a complex process shown on the top of cell mechanisms. The interesting thing is, because it involves so many processes in the cell, it gives us a variety of ways to resist or avoid the virus. Shown on the bottom, we can try to block the entry of the virus, which is typically through the spike protein expressed on it. We can try to block the replication of the virus inside our own cells, stop our cells from making more virus. We can, on the bottom, boost our immune system, our innate immune system with a variety of ways, and improve or enhance the immunity to the virus as well in other ways, including vaccines that we have used for that. Now, of all of those possible ways, 7 ways to interact with the virus and prevent it from spreading, we have listed on the slide a number of possible ways we introduced 2 years ago to do it. The ones in the red boxes are the ones that have from time to time shown effect at reducing the virus. That is remdesivir and monoclonal antibodies on the top have been effective, especially in Delta. Monoclonal antibodies we'll discuss are no longer seem to be effective for Omicron at this point in time. We do know that we've improved our standard of care in the ICUs. We no longer try to immediately ventilate someone because that leads to further damage. We try to prone them and avoid mechanical ventilation and high oxygen if we can in that situation. At the bottom, we now have the introduction of 2 direct-acting antiviral drugs that are oral that can be given in individuals. Those have some significant efficacy, up to 90%. In the old Delta variant, we don't know yet on the Omicron how effective they are. Vaccines at the bottom right have been very effective against Alpha and Beta variants and very effective with the double vaccination against Delta. They are less effective against the new Omicron variant at this time. So we're continuing to look at these type of treatment modalities that we have for it. Despite that, Omicron is increasing. If we look at the progression of the virus, this virus is learning and getting better and better. It started out with the original SARS-CoV-2 virus, which one individual could infect up to 2. That was considered a significant infection rate. But Alpha increased that to 1 person infecting 4 to 5. And Delta got even better, infecting up to 5 to 8 individuals. And we now know that Omicron is approaching the far right. It's almost up to measles as far as infection rate, where 1 person can infect up to 18 individuals. So this very high infection level for the virus is leading to an increase in the prevalence of the virus. Part of that is related to the spike modifications. There are 30 or 40 spike modifications associated with the new Omicron variant. That means that the neutralizing antibodies from prior infection with Delta or prior vaccination, even if double vaccination, is less protective with the new Omicron variant for that. And because of that reason and the higher infection rate, what we've seen is the prevalence of the virus has increased, as shown on this slide. This is an interesting graphic. Hattie feels it looks like a snake. If we look at the tail of the snake in the middle, that excuse me, represents the virus when it started in 2020. And you can see the width of the snake relates to the prevalence of the disease. Relatively limited when it started, a small snake as we evolved through 2020, but there was a significant peak when we got to the winter of 2020, 2021. So January 21, it widened again and the 7-day average of cases increased significantly. With that, we then at that point started vaccinating people, and we saw through April of 2021 a gradual reduction in the cases, got even smaller as we got towards July in the summer. And our administration even predicted maybe we had succeeded in conquering COVID, and it would really go away by the 4th of July in the US, and we could resume our normal activities. Well, that didn't seem to happen. As you can see, the snake continued to get wider in the fall of 2021, and that was related to Delta increases at that point until at that time, Delta reached a plateau sort of, but then we come up to the top of the slide to January. South Africa introduced a new variant, Omicron, with 50 variations in it, and it's just gotten progressively bigger. And you can see the head of the snake is exponentially growing at this point in time with the new Omicron variant for that. And so things like today, we're now up to 831,000 additional cases today. So we were talking about 100,000 new cases a day. Now we're up to 831,000 new cases each day. So I envision at the current rate, we will get to 1 million new cases each day with this Omicron variant for at least a period of time. We do know that this may be a milder variant, so that's good news. But with this many new cases, the first black box shows we're still at 2,348 deaths in the last day. So that's significant. So if this is perhaps twice as infectious, but half as deadly, it still leads to a significant number of deaths. And we're going to perhaps get back to our old death rate of last year, which was peaked at about 3,000 deaths per day. The second box shows that we have proceeded and improved in vaccinations, and about 62% of the people in the US are double vaccinated with this, and about 36% have received their booster shot. So we do have increased vaccination in the US for that. So why is it still succeeding? Well, the next box shows the fact that, unfortunately, the monoclonal antibodies that had success with Delta and Alpha are not being effective in this new Omicron. And the reason is the spike protects itself from the neutralizing antibodies, especially these monoclonal antibodies. So it does not seem to have an effect against the virus in this particular case. The other thing in that box shows that sera from both the Pfizer and AstraZeneca, we do have some data from the Regeneron vaccine as well. After 5 months, the vaccinated serum had barely any effect on Omicron. That means a double vaccinated person at 5 months really has very little resistance against this new Omicron variant. And that explains that if we think of it, it's only the boosted dose that seems to have some effect against the Omicron. And the last box shows that the vaccine dose with the booster has some protection against Omicron. Unfortunately, it's still 20 times less than the effect it had on Delta. So, but it is somewhat effective. So when we say, why is this virus wildly going through the US? It's because our current vaccination, double vaccination, is almost not effective. And even a booster is reduced in protection against the Omicron virus. So at this point, Omicron is ahead of the game and winning at this time. So what do we do at this time if you want to travel or other things? This was the old slide I had showed that vaccination with the booster is protective. For Delta, it was about 95% effective. That's dropped significantly with Omicron. We still recommend double masking or the N95 mask for that protection as well. But even that is not completely protective against Omicron. Isolation is effective if you stay away from people. It's an aerosol dispersion of the virus. So if we can stay away from people 6 feet away outside, that is protective. When you decide if you're going to travel, look at the prevalence in the zone. If it's a high rate, that's going to make it once higher. On the bottom, we show that we had pretty good protection against alpha with all of these prevention methods, reducing our chances of getting it to about 1 in 8,000. With Delta, which was more infectious, it reduced with all of these protective things above our chance of getting it to 1 in 800. Now with Omicron, even practicing all of this prevention, your chance is perhaps still 1 in 80 for getting this. So it's significantly there. We do recommend that you prevent by using all available prevention methods. Shown on the top is vaccination with booster is now required. Masking, unfortunately, is still required, even though you're vaccinated before this. It also requires more testing, and we are way behind on testing in the US. New tests have been ordered, but if you look at the prevalence of this, it's going to require 10 times more than we have in the supply chain right now. Keeping your distance is still a good protection. Stay 6 feet or more away from individuals and avoid crowds in poorly ventilated spaces. Try to do everything outdoors if you can. It is estimated with the prevalence in the US of this new virus, if you go inside to an event with 20 or 30 people, it's almost statistically guaranteed one of those individuals will have the Omicron variant, and you run a high chance of getting it. We want to improve ventilation and air filtration systems for all of our meetings. Hand hygiene and cough etiquette is still important. And if you get sick, stay home. You are potentially a carrier of this virus, and try to prevent spreading it on your own in that situation. We also want kids to go back to school, so we're recommending that all kids greater than 5 years of age who are equal to it get vaccinated at this point in time for it. That they should continue to wear masks in school, continue to separate, ideally 6 feet or more at that point, motivate teachers to reduce circulation of the virus by moving students around, try to only move teachers around and keep groups isolated or cohorts at this time. Try to monitor the
Dr.
individuals.
Balmer,
Don't let them
I
in
just wanted-
and reduce exposure. I'm finishing right here and then I'll get to it. Reduce exposure. We do need quarantines, and clean your hands at that point in time. So lastly, that's what we can see is we've dealt with acute and post-acute COVID. The fact is the virus on top is winning at this time, and we are going to have to learn to live with it at this time, and it's going to be with us for years. That, yes, Hattie, happy to answer your question.
So Dr. Overbright, please unmute yourself in the bottom left corner of your screen. And Dr. Overbright has a question for you. I want to just say that we're going to shift to our obesity topic quite quickly here. Go ahead, John.
Yes, thank you very much. I thought that was superb, Dr. Balmer. Excellent summary. From a public health perspective, in Sweden, I'll mention some things that you might like to comment on. One is that we're really not using test rates now, or even positivity rates on tests. We're focusing on admission and ICU, mainly because the situation is very different in terms of predicting who tests positive, the impact on our hospitals. The second thing is the difference between the lab studies of immunogenicity and some of the real world observations that bring in more the T cell memory. The second thing is the sort of approach or model we use in public health is a kind of a Swiss cheese model where the first layer is masked, the second layer is 2 meter distance. But from a public health perspective, we emphasize less the individual, but the structural, the way things are set up. So the layouts that either enable flows to have 2 meters or force the flows. Then another Swiss cheese layer of hand washing, another Swiss cheese layer of ventilation, and one towards the end is vaccination. And then there's the treatments, and the last one. And I understand monoclonal treatments are not affected against Omicron, whereas some of the antivirals probably will be. The last thing to comment on is relating to this session is how important better management to reduce deterioration by primary healthcare is. And we certainly in Sweden want to do better in more assertive treatment of chronic illnesses, for example, obesity, asthma, COPD, diabetes, heart disease, and mental health that complicates self-care, and then also for carers. I don't know if you want to pick up or comment on any of those. I'll stop there. Thank you very much.
Well,
it's great to have you with us here in the United States, John. And now I think Bill is going to introduce Dr. Purnell. If Albert, you could share the slides.
Well, thank you very much for those comments from across the pond from Sweden. We're certainly looking at all of that, and we realize that as fast as we come up with prevention methods and others, the virus is continuing to work with us on its way of improving, and it's going to be a struggle, I think, at this time. And unfortunately, in the US, we're now starting to, as John mentioned, overcome some of our healthcare professionals. One is as they get infected and drop out, they're tired of working. They've been working for 2 years now on this, and fatigue is a big aspect for it. So we have all of those things, yes. And I could talk about Omicron and this for 2 hours, but we're going to move on, thank you, with Jonathan Purnell. And it actually is connected because I didn't mention it at the time, but one of the most significant risk factors for COVID in young individuals is obesity. And so we now know that obesity is a risk factor for getting COVID and suffering from the morbidity of COVID. And it is probably the most important risk factor in young people. So it's a significant aspect for them. Obesity as well is a significant risk factor for a variety of diseases, cancer, cardiovascular disease, stroke, etc. So we're delighted today to have Dr. Purnell, who leads the preventive cardiology program at Oregon State Health and Science University, which we usually call OHSU. He's board certified in endocrinology and obesity, has research interests in obesity, metabolic syndrome, dyslipidemia, and diabetes. And he's done research in a variety of things for that. He is a leader in obesity and editor on many publications, and he is a fellow in the organization. We're delighted today to have Dr. Purnell talk about obesity, which continues in the US. And what the story I have here is that I just found out in the United States, we've struggled with obesity. He'll talk about where 2/3 of us have it. But in truck drivers in the US, the obesity ratio number is now 86%. So if there's something that is growing as fast as COVID, it is obesity at this time. I'm delighted to introduce Dr. Purnell to discuss it with us today.
Thank you, Bill. And it's an honor to be here, and we'll turn from acute diseases to chronic disease. I'm looking forward to Dr. Alba's talk as well. I'm not going to be speaking as much about definitions of obesity, except for one part that has to do with some of the controversies around the paradoxes with obesity. Are you able to see my full screen now?
Yes.
Great, thank you. I have two disclosures. One is that I do receive consulting fees from Novo Nordisk, one of the sponsors of this program, who also makes 2 anti-obesity medications. And I will be including just briefly some off-label recommendations for use of medications. I have a lot to go through today. I was asked to cover a pretty wide range, but I really wanted to make sure, and I try to do this in every talk I give about obesity management, is to spend a little bit of time on the physiology. This is an area of weight regulation. This is an area that we don't teach very well to medical students, and so a lot of practitioners and certainly non-physician or non-provider populations haven't really been exposed to it much. I'm going to then talk about obesity specifically as a direct and indirect cardiovascular risk contributor, and then try to address 2 obesity paradoxes. There are many described paradoxes of what happens to people with obesity, but I'm going to try to focus on 2 of those. And then finally end up with our recommendations around approach to treating obesity once it is manifest. So I'm not going to spend a lot of time today talking about the type of prevention that will be very important for many of this audience, like trying to prevent people from developing overweight and obesity in the first place. What I'm going to be focusing on today is what happens after overweight and obesity becomes manifest and that patient is sitting across from you in your clinic office. How do you approach that? I'm happy if we have time afterwards to lend my 2 cents to the prevention part of it in a population basis. And then I'm going to focus on of all the myriad of outcomes with obesity, primarily on cardiovascular outcome risk. So starting with physiology, if I were giving this talk about diabetes, typically what you do is we talk about diabetes being a disease of 3 major organ systems: the liver, the pancreas, and the muscle. Well, weight regulation involves, we all have it, all our bodies are regulated to a certain extent, and that physiology involves interaction between 3 major organ systems in the body. The first is the brain, which includes the hypothalamus and the brainstem, and today I'm just going to focus on the hypothalamus. And these areas of the brain are in direct communication with both adipose tissue stores as well as the GI system. And so it's the interaction of these 3 systems that determines our body weight at any particular time. And the way it works is that as we eat a meal and digest the food passes from the esophagus to the stomach to the intestine. The process of absorption of those nutrients across the lining of the intestine triggers secretion of a pattern of hormones that go into the blood and bind to receptors in the neurons in a part of the hypothalamus that I'm going to show you in a second. The majority of these hormones these hormones are shown just in partial listing here. Cholecystokinin, insulin, amylin, PYY, and GLP-1. When those hormones bind to those receptors, they convey a sense of fullness to our brain. We call them satiety factors. At the same time that they're being triggered in their response, the passage of those nutrients through the stomach and duodenum inhibits secretion of another hormone called ghrelin. And ghrelin has been discovered as a hormone that binds to the same neurons in the brain as these other ones. And instead of conveying a sense of satiety, actually conveys a signal of hunger to the brain. The amount of calories that we eat determines the amount of production of these hormones and the degree of suppression of ghrelin at the time of the meal initiation. We don't count our calories. None of us do. If we do, we're not very good at it. But our brains still know how many calories are coming in through a summation of the levels of these hormones and the suppression of the ghrelin. And that listing I gave you is just a partial listing of all the different factors, hormones and bile acids microbiome products that are involved with that digestion process. This is what we now know is the stomach and the intestine is the largest endocrine organ in the body. It produces over 100 known hormones today. Now stack that up against when I did my endocrine fellowship with the 5 from the pituitary, it actually dwarfs that. And when I talk to residents now and fellows about if you want to go into endocrine and you want to do research in this area, the vast frontier of the area of greatest discovery yet to be done is actually in the GI system. And all of these compounds and factors have been implicated in both food intake, body weight regulation, and glucose and lipid metabolism. So with a meal, as all of us eat our meal, I put together a graphic that sort of illustrates what the brain is sensing and how we're responding to those changes in those satiety factors and ghrelin. So let's say time point 0 is initiating a meal, let's say lunch. Then as the absorption occurs, then you can see a progressive rise in the satiety factors, the fullness factors, and a progressive suppression of ghrelin. And these levels of these hormones rise until our brain gets to a point where our brain says, okay, we're satisfied. Let's put down the fork and be done with the meal. And then as that farther away from the meal, you get those fullness hormones drop off, and the stomach and duodenum start to make more ghrelin. And ghrelin levels continue to rise 2 to 3 hours later until there comes a point where your brain goes, okay, it's been 3 hours since lunch, let's go make some dinner. Or boy, I could really use a snack right now. I'm pretty hungry. So let's say, and I use the example typically with the medical students, that this is breakfast. And you normally have a bagel with breakfast, but today you have to share that bagel with your partner, so you only have half a bagel available to you. But that bagel was able to carry you through to lunch before. Well, now what your brain sees is half the amount of the fullness factors that it saw before. So it's not really satisfying. It's going, hey, John, all right, food's there, but where's the rest of it? And I've only suppressed the ghrelin by about half as much as well. So not only do I do not get the full measure of suppression of that hunger hormone, it comes back to baseline or that level, the triggering hunger, faster. So that half a bagel doesn't leave me as satisfied. And now instead of making it through to lunch, it's now 10:30. I'm looking at my watch going, boy, I could really, maybe I should have an early lunch today. So there's 2 important parts about this aspect of the physiology of weight regulation. As I mentioned before, we don't count our calories, but still or if we think we do, we're pretty lousy at it. But still our brains are able to understand how much we're eating through this signature of this confluence of these hormonal signals. And the other is that these behaviors that others observe in us, that we observe in ourselves, like putting down the fork because we're satisfied or looking for food because we're hungry, are driven by internal biological signals. These are signals that are going to be there whether we want them to be or not. We don't control them. They control us ultimately. So in addition to those signals, there is another hormone secreted by fat tissue in proportion to fat cell size and number. So this is leptin, and this reflects how much weight we carry. So as we gain weight, our fat cells enlarge, leptin levels increase, and it binds to the same neurons in the hypothalamus that those gut hormones do. More importantly, as we lose weight, leptin levels, our fat cells shrink and leptin levels drop. So this part of the brain, the hypothalamus, is continuously integrating these 2 sets of signals, moment to moment, meal to meal, day to day, to answer 2 questions. 1, do we weigh what our brain thinks we should weigh? That's the leptin signal. And the other is, are we eating sufficient calories to maintain that weight? And we call this part of the brain, and that's from the gut hormones. And we call this part of the brain the set point. Now, in concept, the set point for weight is no different than a set point we have for blood sugar levels or for blood pressure or any other homeostatically controlled vital organ system, process in our body. It's not an actual weight, it's a range of weight. And it typically So the job of this part of the brain is to keep our weight within 5 pounds up or down of what our brain thinks of as normal. I want to spend a moment here on the hypothalamus because, as I mentioned before, this is command central for integrating these signals from the periphery, determining where we are, and then what to do about it. And it's also the place of the brain where the current anti-obesity medications are known to function, and where most of the bariatric surgery mechanisms are also thought to be playing a role. So if we blow up the part of the hypothalamus I've been showing you in a graphic, this part of the hypothalamus from left to right here is 5 millimeters. Using the other side, that's 10 millimeters total, on the other side of the third ventricle. So this part of the brain is basically the seat of how much we weigh. And one of the key neuronal bodies that controls this weight is in the arcuate nucleus, which is right below the ventromedial hypothalamus. Within this arcuate nucleus is a grouping of neurons that contain the gene pro-opiomelanocortin, or POMC. A lot of people know this as the precursor for ACTH, but it also can be alternatively spliced to make alpha MSH, alpha melanocyte stimulating hormone, which, if it's present in the skin and the hair, is responsible for darkening of the skin and the hair. But alpha MSH in the hypothalamus binds to the melanocortin 4 receptors in the paraventricular nucleus. And when it activates those receptors, changes food intake, reduces it, and increases energy expenditure to ultimately cause a reduction in body weight through reductions in body fat mass. So right next to this body of neurons in the arcuate nucleus is another body of neurons that contain the neurotransmitters NPY and AGRP, a GUDI-related protein. So think of these two neuronal bodies as insulin and glucagon, alpha and beta cells within the pancreas, sympathetic and parasympathetic nervous system. This is within the peripheral nervous system. So think of these as yin and yang to one another. So when NPY and AGRP neurons are activated, the AGRP that's secreted is an antagonist to the melanocortin 4 receptor. It inhibits the stimulation of the MC4 and basically blocks this pathway from being activated, and instead activates systems through the lateral hypothalamus to cause positive energy balance through increases in food intake and reductions in energy expenditure. Now, these systems are controlled, as I mentioned before, by leptin and insulin, which is both a satiety factor as well as a adiposity factor. But when leptin and insulin are present, that signals to the brain food and weight sufficiency. So in that situation, there is activation of the POMC alpha MSH melanocortin 4 system to slow down any more food intake or reduce it, and inhibition of the NPY and AGRP system. On the other hand, in food insufficiency states or during weight loss, leptin and insulin levels drop. There is a removal of the stimulating of the pathway, the melanocortin 4 pathway. There's a removal of the inhibition of the NPY-AGRP system. So that tips the balance then towards positive energy balance. And so in this way, we kind of go through our day with insulin and leptin levels kind of rising and lowering to maintain things in a homeostatic system. So in this model, based on our understandings from animal work and from humans, we now know that obesity, the development of unwanted weight gain leading to overweight and obesity, results when leptin resistance occurs. Now, there's very rare patients who have leptin deficiency, but majority of patients have developed leptin resistance. And this is analogous to insulin resistance in type 2 diabetes, where higher insulin levels are required to generate the same intracellular signal and normalize glucose levels. When you have leptin resistance, the brain requires higher leptin levels to generate a new homeostatic set point or balance and come back into neutrality. Now, in order to generate a higher leptin level, we need to basically raise our body weight. And that's what happens when you go through that period. Now, that set point rising from leptin resistance has a couple unfortunate aspects to it. One is that for the vast majority of the population who experience this unwanted weight gain, the directionality of this change in the set point is one way. It goes up, but it doesn't come back down on its own again. Even if environmental changes had contributed to it, once those physiologic switches are flipped, changing the environment after expression of overweight and obesity for the majority of patients doesn't allow resetting of the set point down below. The other is that when the set point rises and the brain thinks a higher weight is normal, the brain defends that weight against the patient's best efforts, even though it might be contributing to diabetes risk, sleep apnea, or other things. The brain doesn't know that set point is detrimental in health, but if it sees a drop in leptin, drop in the gut hormones, or both at the same time, it will defend that weight, slow down any weight loss that might be occurring, and bring patients back again. So another aspect of this system, and in terms especially with regard to expression of overweight and obesity, that I don't think is appreciated enough by the general population, and certainly not by providers, is that the peak age for obesity, not just here in America, but around the world, and this is a multi-country study published in the New England a few years ago that looked at obesity rates within different countries, and this SDI just describes those countries as low, middle, and high income countries, basically. So it's multiple countries around the world. But peak age obesity is around 60. So what we know is that women particularly are vulnerable for expressing unwanted weight gain. So this neurologic window open up in puberty and pregnancy and menopause, but men can do it almost any time. But you can be normal weight in childhood, in your 20s, 30s, 40s, and still in your 50s, express unwanted weight gain and develop obesity from acquisition of leptin resistance. So I always tell my patients, being thin and young is kind of like investing in the stock market. You're not guaranteed gains in the future based on previous stock performance. Just because you're thin when you're younger doesn't mean that you're not going to express this when you're older. And in fact, because we can't predict it very well, we really have to be exercising caution, not necessarily caution, but exercising advice on healthy eating habits and regular activity to everybody in the population. Maybe after 60, not so much, but we still want people to be healthy and keep their muscle mass up then. What we know now, and I think what Dr. Alba is going to talk about too, is that in the United States, more than 70% of our population currently meets criteria for overweight and obesity. That means less than 30% of us will make it to our 60s in a healthy weight range. So that's a staggering figure that has disproportionately affects patients and minorities that I think she's going to talk about in a little bit. So this is and think about diabetes. Diabetes affects 14%, 12 to 14% of our population now. So the number of people who are affected by obesity is now in the 40%. 3 times as many people have the chronic disease of obesity as the chronic disease of diabetes. So one of the main take-home points that I try to convey in my talks, if nothing else you take away from this, is that we consider obesity to be a chronic disease. And it's similar to other chronic disease definitions in that blood pressure, diabetes, cholesterol, we have these vital homeostatically regulated systems that in this particular case for weight regulation keeps our body in a set range. But then due to pathophysiologic alterations, that set point rises and leads to a higher level of defended body weight. And then as a result of that excess accumulated body fat, that leads to impaired health long-term, which there are over 200 identified complications of obesity today. Let me just kind of focus in on some of the mechanisms of obesity and cardiovascular risk right now. I'm going to address some of the paradoxes in the next section, but one of them has to do with the the well-known relationship between increasing BMI. So if you increase the quartile of BMI category, that it is associated with increasing risk for type 2 diabetes, cardiovascular disease, and mortality. What we don't talk a lot about, I think we need to talk more about, is that adiposity in the sense of where we carry our weight, not just how much of our weight we carry, is also a very strong risk factor. And in fact, the proportional contribution of central weight distribution and visceral fat to these risks is higher at the lower BMI. So you can be have all the complications of obesity at what we consider normal BMI if you carry the majority of your weight around your middle, and that happens to fall within the visceral area. And what we come to understand is happening is that if you kind of can peer into the visceral area around, so you're looking with a CAT scan past the skin, past the abdominal musculature, and into where the intestines are. The black area here represents accumulated visceral fat. And this is comparison to a person who has more subcutaneous fat and little black area here within the abdominal musculature area, representing more of the, say, the apple figure, the pear figure versus the apple figure. And what I like about this picture is it shows that central obesity is an equal opportunity offender. It will affect women and men at the same time and have the equal consequences. So the reason why this is, we spend a lot of time talking about visceral fat is that this fat depot has a higher turnover in terms of free fatty acids and more inflammation in it than subcutaneous fat. And most importantly, it has a drainage system, a pipeline, so to speak, in the portal vein, where all of the fat from here drains right into the liver. Now, it doesn't go into the peripheral bloodstream and gets diluted, it goes right to the liver. And depending on how the liver handles that extra load of factors, the free fatty acids and inflammatory factors, it may burn it off or get rid of it, and you may have no problems. But instead, if the liver can't handle that extra load, it can accumulate there within the liver tissue itself, and that gives you a diagnosis of non-alcoholic fatty liver disease. It also can result in increased packaging and delivery into the bloodstream as VLDL containing triglyceride particles. So your triglyceride levels go up. And then through action of an enzyme called CETP, cholesterol ester transfer protein, HDL cholesterol goes down. Now, that results in what we call dyslipidemia, and is about a twofold, just by itself, independent of LDL cholesterol, about a twofold increased risk of heart disease just for that alone. Now, both visceral or central adiposity and general adiposity can result in reduction in secretion of another adipocyte hormone called adiponectin, which we think can contribute to peripheral insulin resistance. But also reductions in adiponectin and this increased free fatty acid load of the liver and this accumulation of lipid within the liver is also associated with impairment of insulin signaling or insulin resistance at the level of the liver, which results in increased hepatic glucose output and increased fasting glucose. So basically, all this illustrates the pathways that we now understand leads to what we commonly refer to as metabolic syndrome. And it has the real primary area or abnormalities associated with the visceral fat for this. So as I mentioned before, you can have all the complications of obesity in a normal BMI category if you carry that weight right around your middle. Now, in addition to the visceral fat around the internal organs there, we also talk about visceral fat accumulation around the heart. And when this happens in the interventricular group where the arteries are, that can also, we think, convey increased risk for plaque formation locally. You can have increased epicardial fat, not shown here, but it's the fat around the heart that is thought to be a delivery system for inflammatory markers and communicates with the heart itself through proteomic analysis and may contribute to myocardial dysfunction. And then we also have increased accumulation of fat within the muscle itself. So in this part of the talk, we started off acknowledging years ago general adiposity as a risk factor for heart disease and mortality. And then with the advent of imaging studies, became more refined to look at regional fat distribution, visceral fat. And then with advancements in spectroscopy methods, we can now talk about ectopic fat in places it shouldn't be, non-fat depot areas, muscle and liver, as also being instrumental in pathophysiology. So I just want to have a quick discussion here about how different organ systems can be influenced in obesity as a result of insulin resistance. So as I mentioned, obesity causes insulin resistance, and then that leads to high levels of insulin to compensate for that to maintain euglycemia. So originally thought that when insulin resistance develops, that all organ systems in the body get it. We know the brain becomes insulin resistant, we know the muscle does, we know the liver does. But subsequent work has shown that ovaries remain insulin sensitive, and in women who are predisposed to PCOS, that can result in higher levels of androgens. But work from Dale Abell and his colleagues have also shown us that cardiac myocytes can remain insulin sensitive as well. So while the skeletal muscle remains insulin resistant, the heart muscle tends to remain insulin sensitive. And through activation of the insulin receptor and the mitogenic pathway within the heart, it is thought that this is the main pathway that results in cardiomyocyte hypertrophy and basically impaired LV relaxation, or what we now call heart failure with preserved ejection fraction. And over time, under the influence of continuous sort of insulin action, along with other complications of weight, including hypertensive cardiomyopathy, ischemic cardiomyopathy, that can then result in cardiac decompensation later on and heart failure with reduced ejection fraction. So summarizing this part of the talk, obesity itself, particularly central obesity, is both a direct and indirect contributor to cardiovascular disease. So in the case of direct contributor, the increased plasma volume from the fat, the visceral fat around the epicardial fat, can all promote and worsen heart failure with preserved and reduced ejection fraction. The expression of the comorbidities, hypertension, insulin resistance, dyslipidemia, sleep apnea, chronic kidney disease, all can promote plaque formation, heart failure with preserved and reduced ejection fraction. And then, as I mentioned before, ectopic fat is contributing as well. So there's a lot of different mechanisms there. So turning now to two obesity paradoxes that I was asked to cover today. And I'm sorry if I'm going a little bit faster than I normally do, but I do have a lot of ground to cover. So as I mentioned before, historically, we have known that body weight based on Northern European populations, like, or at least descendants of Northern European populations, like here in America, there is a J-shaped curve showing a relationship between body weight, or in this case, body mass index, and increasing risk of death. So on these, this happens to come from a cancer registry study of about 750,000 men and women. But in this particular case, many of these patients who had lower body mass index associated with higher mortality were subsequently found to have chronic diseases, cancers that were undiagnosed and other things. But where we came up with our current normal weight of 20 to 25, overweight 25 to 30, and 30 to above being obesity, came from these data showing that both men and women have this J-shaped curve, and increasing mortality rates began above 25 and start to go up. And these include, if you want to look at disease-specific mortality rates, they included heart disease, stroke, as Bill Baumer mentioned earlier, cancer, and very, very particularly diabetes. But that was in the 1980s and 1990s. But then, and in the 2000s, epidemiologic data out of the CDC started showing that instead of having the J-shaped curve showing the lowest mortality at 20 to 25, it now appeared that the lowest mortality was in the overweight to obese category. And so this led to the supposition, well, maybe obesity isn't that bad, and maybe we should be not really focusing on it. And so what happened between the 1970s and 80s and the 2000s? Well, if you look in the background of what was happening, heart disease mortality rates were already declining. Stroke was already declining. And this had a lot to do with our improvements, starting with managing patients with sudden death in the community, to improvements in ICU care, to also including a number of other improvements in medical management as well. There was a reduction in smoking, lifestyle increased as well. But statins became introduced. Now we have PCSK9 inhibitors. We have better blood pressure medications and lower targets with those. We have newer agents for congestive heart failure, which is a big cause of mortality, especially with ischemic heart disease, and just using regular aspirin. Diabetes meds have been, as we'll talk about in a little bit, have been, especially in the last 10 to 15 years, have allowed us to reduce cardiovascular mortality and diabetes as well. But just the diabetes meds alone that have been necessary to help contribute to this lower mortality rate that we see now at the higher levels cost the United States $327 billion in 2017 dollars. So in 2017, it was just diabetes alone was a $327 billion year industry. So the price that we've paid for shifting this J-shaped mortality curve towards overweight and obesity status has been to treat these conditions rather than the proximal cause of the traditions. And this is data from over 195 countries with millions of patients, showing the incidence and relationship between cardiovascular disease, cancers, chronic kidney disease, and diabetes as a function of BMI from around the world. And you can see that from between 1990 and 2015, the peak shifts over a little bit, so that the relationship, the peak mortality rates for these diseases now occurring at 30. And over 70% of the deaths from obesity are due to cardiovascular disease. So it's still a major contributor. But let's turn down to the other controversy. So the other paradox. Well, what if my patient is metabolically healthy? Doesn't mean that they're okay, and we really don't need to do anything about it. Well, this is a cross-sectional study that came out recently using coronary artery ultrasound and coronary artery calcium score to quantify plaque number in patients who are normal weight, overweight, and obese, and coronary calcium scores in the same categories. Now, these are both considered subclinical measures of vascular disease and surrogates for major atherosclerotic coronary events. So what you can see is that if you're metabolically unhealthy and you're normal weight, yes, being metabolically unhealthy really does separate you from the healthy category. If you're overweight, the same is true. But by the time you get to become obese or develop obesity, there is no significant difference between the number of ultrasonographically identified plaques, whether you have healthy or if you're categorized as unhealthy obese. And the coronary calcium scores show the same thing. By the time you get to the obese category, coronary calcium scores, the distribution skews towards the unhealthy population, as you might expect, but there's no significant difference there anymore. And if you look prospectively, and this is one of the largest prospective studies in America that have been conducted, the Nurses' Health Study, 90,000 women followed for 30 years, were classified as being metabolically healthy if they had no diagnosis at the beginning of diabetes, hypertension, or hypercholesterolemia. And they were unhealthy if they had at least one of the above. And when they looked at patients who were normal weight or obese or with obesity at baseline, and then followed them up to say what happened over time to those patients, with the referent category being normal weight at baseline, metabolically healthy at follow-up here. If you're normal weight at baseline and metabolically unhealthy at follow-up, but still normal weight, then you had almost a twofold increased risk of this particular case, cardiovascular disease. If you were metabolically healthy at baseline and then metabolically healthy at follow-up compared to the normal weight ones, you still had about a 60% increased risk of heart disease, cardiovascular disease, and almost a threefold increased risk if you were unhealthy at follow-up. So the main point is that being metabolically healthy, even during a 20-year follow-up timeframe, still leaves you at risk for atherosclerotic disease. And even those people who were metabolically healthy with obesity at the beginning developed unhealthy status. 84% of them with obesity were in an unhealthy status, and only 6% of the population remained metabolically healthy after 30 years. So this says that, at one snapshot in time, being metabolically healthy doesn't mean you will be that way the rest of, for over the 20 years. And this was a large study from the UK Biobank participants where they took less stringent, these categories we kind of consider where you have an expression of the disease, hypertension, diabetes, and things, and looked at metabolic categories that were sort of lower level, lower thresholds. So systolic blood pressure less than 130, and diastolic less than 80 was considered healthy. Above these was considered unhealthy. LDLs above 116 considered unhealthy. Triglyceride HA1C above 6%, not 6.5%. And what I want to focus on here is they looked at patients without obesity and with obesity and followed them up. And I just want to focus on using the referent group of being normal weight or non-obese, and then remaining metabolically healthy as the referent group. Those who remained metabolically healthy with obesity during that same time frame still had a fourfold higher risk of diabetes during that follow-up time frame of about 11 years total. Still had a 20% increased risk of heart disease, 60% fatal MIs, almost 80% increased risk of heart failure, and 22% increased risk of all-cause mortality. These are not trivial numbers on long-term follow-up. So the bottom line is, from these obesity paradoxes, which I put in a question mark here for a good reason, is that obesity was and still is considered to be a leading cause of coronary disease and premature mortality. Even metabolically healthy persons with asymptomatic vascular disease are increased risk of coronary disease, and most metabolically healthy patients with obesity will become unhealthy over time. So it's kind of we consider it now a misnomer to use these terms and not doing our patients any service if we choose to ignore that and wait till they get diabetes or hypertension. So I want to turn now and spend the last part just talking about our approaches to weight management once we've identified patients with overweight and obesity. And this is the classic line that basically we were taught in medical school, that you hear from your family members if you're suffering with obesity, that you hear from your provider, which is basically eat less and exercise more. You just need to learn how to take care of yourself and do the right thing. Well, if you're using evidence-based medicine to sort of recommend to a patient what program they should use to eat less and exercise more with, you would choose the diabetes prevention program. This really is the one that combined diet and lifestyle and had long-term outcomes that were meaningful and beneficial. So in this particular study, patients who were overweight and with obesity who had prediabetes were randomly assigned to 4 arms. There's only 3 here where they were finally published: usual care, placebo, metformin, or lifestyle. And lifestyle was a combination of a low-calorie diet, about 250 kcals per day reduction, a low-fat diet, but whole foods. And patients met with dietitians on a regular basis throughout the entire program. Exercise was up to 5 to 6 days of aerobic exercise a week. They had personal trainers. They went through VO2 maxes. They verified during the trial that they were adhering to the recommendations. And what you can see is that at the end of 1 year, the average weight loss for the group assigned to lifestyle was about 7 kilograms. And typically this represents 7% because the average BMI is about 100 kilograms in this group. So about 7% in 1 year. And compared to really no change in placebo and about a 2 kilogram weight loss with metformin. And so people who use metformin as a weight management tool, this is what they usually say, oh, this metformin is good for weight loss because you get about a 2 kilogram weight loss, 2% weight loss with it. But even though the participants in the lifestyle arm continued their regular activities, they continued to meet with dietitians. So this is a very intensive lifestyle program during the 4 years. Instead of continuing to lose weight, they actually backtracked. So the average weight loss at 4 years was about 4%. And what we now attribute this to is that physiologically regulated system in the brain that is sensing these changes in the macronutrients in the activity and slowing down the weight loss and then bringing the patients back towards baseline, although not fully. So I'm going to skip ahead of there. If patients long-term achieve 4% weight loss, so let's say about 8 pounds for someone who weighs 200 pounds, that's not a lot. But if we're honest with our patients before we tell them to eat less and exercise more and get them into that program, if we're honest with them, we'll tell them that this will result in about 8 pounds of weight loss after 4 years. The reason to do it is because that's important for health, primarily because this resulted in a 58% reduction, nearly 60% reduction in progression to type 2 diabetes compared to placebo. That's a big outsized gain on obesity-related complications, compared to about a 30% reduction with metformin. Many providers still to this day, if they see a patient with prediabetes, will reach for metformin rather than advocate for lifestyle, even though that's half as good in terms of that, benefiting. So in terms of lifestyle, what we now recognize is that if you have a patient who's in the overweight or obesity category, they've been there for a while, what lifestyle gets you, eat less and exercise more, is from the top of that range that your brain set point is capable of doing to the lower part. So you improve it a little bit. But what it doesn't do is get you down to a different BMI category that might be in a healthier weight range, in a overweight or normal weight category. And that's where the other therapies I'm going to talk about in a minute show. So with this lifestyle, you could say, well, maybe there's some metabolic memory going on there. Maybe we're benefiting them with a reduction in diabetes. But if you look specifically at cardiovascular outcomes, with more than 20 years of observational follow-up since the original diabetes prevention program study was published, has not been shown to reduce benefit for cardiovascular disease. And when the NIH repeated this in patients with type 2 diabetes already, who were high risk for heart disease, gave them the same lifestyle intervention, got the same weight loss with patients with type 2 diabetes, about 4% long-term, there was no difference in the 4-point primary major atherosclerotic complication event rate, the MACE, in those who got lifestyle versus those who didn't. And the study was stopped after 10 years. So lifestyle alone is important for many, many reasons. But as a treatment for obesity, it's not very good. What you will hear our nutritionists or our dietitians tell our patients is not so, we don't use words like low carb, low fat, keto diet, but actually have been swayed in the last several years by the epidemiologic data, both here and out of Harvard School of Public Health, as well as internationally, showing that it's not so much the macronutrient content that's important, but the types of foods we're choosing to eat. So making healthier food choices, primarily plant-based and whole foods, avoiding processed foods, have really been shown to have positive benefits on cardiovascular outcomes and weight management. And so I actually tell my patients to pick up Michael Pollan's book and follow the advice from that standpoint. And riffing off of Michael Pollan's eat whole foods, meaning avoiding processed foods, not too much and mostly plants, I would also say that, joining a gym and putting on Lycra is good, it's important, but actually we need to be active throughout the whole day. So because our bodies can downregulate our energy expenditure to hold on to weight when we're not exercising. So it's better to be active as much as you can throughout the day at work and home. So in terms of a graphic, lifestyle gets you about 4% weight loss. What we understand now is that if we want to have sustained weight loss that's meaningful, we need to interfere with that brain set point, how the brain senses and responds to those feedback signals, and prevent those counter-regulatory adaptations in appetite and energy expenditure, and continue it long term. Whatever you do that works, it's the rest of your life. There's no resetting the set point down below. So in terms of anti-obesity medications, I've been using these medicines now for about 25 years since my fellowship at the University of Washington. And I try to point out, these are not new. These are recommendations for the American Academy of Family Practice from 2013. So almost 10 years now, that there are criteria for when to consider pharmacotherapy, anti-obesity medications, BMI of 30 or greater without any comorbidities, or 27 and higher in the overweight category with an obesity-related comorbidity, which typically is hypertension, hyperlipidemia, diabetes. In my mind, can include NAFLD, osteoarthritis, PCOS, sleep apnea as well. So these criteria are out there for primary care docs and specialists alike. It doesn't have to just be the specialty doc. And here are currently the 5 approved medicines by the FDA that are considered safe and effective for use long-term. They are the combination of bupropion and naltrexone, known as Contrave, liraglutide, a GLP-1 receptor agonist at 3 milligram dose, phentermine, 1/2 of the old fen-phen that was not associated with heart valve issues or heart failure issues, and the combination of phentermine and topiramate, now also known as Qsymia, and then the other GLP-1 receptor agonist, semaglutide at 2.4 milligrams. Now, each of these drugs binds to a separate receptor in the neurons in the brain, and when those receptors on those neurons align with the pathway in the patients that got them to overweight obesity status, then they act by amplifying the fullness signals coming in and diminishing the hunger signal. So in the past, these were referred to as appetite suppressants. How I refer to them as appetite control medications, because it allows the brain to be happier to lower body weight, typically around 10% before the brain figures out something's going on and puts a stop to further weight loss. They vary depending on the drug. So the drugs have variable weight loss even within a population who take them, but also between them, with the least amount of published weight loss associated with the Contrave combination, bupropion and naltrexone, but approaching 15% weight loss, or 15% weight loss with the semaglutide 2.4 dose over 1 to 2 years. So this one just came out last summer. It's probably the newest kid on the block. But these are, as I mentioned before, all considered safe and effective for long-term use. In terms of tips when managing patients with overweight and obesity, lifestyle is always attempted first and continued long-term. Just like we want patients who have type 2 diabetes and hypertension to be on healthy diets, be regularly active, and in the case of hypertension, to be on a salt-restricted diet. We don't say, here's your ACE inhibitor for your blood pressure. Oh, by the way, you can have all the salt you want. So it's assumed that patients will continue any lifestyle recommendations for them. And these treatments are long-term. They are not stopped unless patients have side effects to them or pregnancy is desired, because they're all considered category X for pregnancy. And as I mentioned, the weight loss averages are 6 to 15%, and they all improve cardiometabolic risk factors. And I thought it's easiest to kind of illustrate this with a patient of mine who I saw a few years back, a woman who started off at 150 pounds and over about a 12-year period of time, gradually put on weight, saw my endocrine colleagues, got ruled out for Cushing's syndrome. By the time I saw her in 2017, she had nearly doubled her weight up to 287 pounds. Her BMI was 44. She had sleep apnea and osteoarthritis, and her TSH was normal, just to double check that before I started on therapy. Her lipid abnormality was characteristic of the metabolic syndrome, where you have a high triglyceride, low HDL, and a modest elevation in LDL. And she was pre-diabetes to the point where she nearly had diabetes. Now, a lot of my colleagues would say, okay, let's give her a statin and or a fibrate, treat her lipid disorder, let's get her on metformin, and let's get her A1C down. So instead, what I did was I started her on phentermine and got her up to therapeutic dose, and she lost about 5 to 10% of her initial body weight. At this point, with that amount of weight loss, triglycerides came down and HDL came up a little bit. And then I initiated topiramate, got her up to therapeutic doses for that based on the randomized controlled trials. Now she's close to 15 to 20% down from her weight, or 15% down from her weight. Now her triglycerides are below 150. Her A1C is in the normal category, and her blood pressure is fine. So contrary to conventional wisdom, these drugs are not dangerous for heart rate or blood pressure. And in fact, most of the prospective data, or the prospective data does show that with weight loss, you have improvements in blood pressure control. So rather than, instead of reaching for the traditional dyslipidemia or hyperlipidemia and diabetes drugs, you can manage the proximal cause of those conditions with weight management. Plus, they get the benefits of the weight management at the same time. Now, if you look at taking the medications and looking at the cardiovascular outcomes trials, which is very important, Contrave, that bupropion naltrexone combination, did undergo a MACE outcomes trial that was stopped prematurely for reasons I won't go into. But the data that we have showed that it was non-inferior, meaning that taking Contrave did not increase your rate of major adverse cardiovascular events. It was considered neutral in that scenario. Phentermine, when selectively used by itself or in combination with topiramate, has not undergone randomized controlled trials, but there have been a number of very large cohort studies, big data studies, and they're listed down here in terms of evidence. At the very worst, they're non-inferior, meaning there's no increased risk of cardiovascular disease. And in fact, several studies have shown that with the benefits of weight loss with using this med, there's actually a reduction in MACE. Where we really have strong evidence of improvements in cardiovascular risk are with the GLP-1 receptor agonists. So liraglutide and semaglutide, both have been used for diabetes for a long time. And while the obesity-related clinical outcome trials are still pending, we have evidence from the type 2 trials where they showed reductions in MACE and mortality of about 13% for 12 to 13% for liraglutide, and 26% mortality and MACE reductions with semaglutide. So we actually have evidence that these GLP-1 receptor agonists not only improve weight, not only improve cardiovascular outcomes, not only reduce progression of diabetes to 80%, but they also improve MACE outcomes. And so the way I sort of picture the role of medications is that lifestyle is important, it should be continued, but using or adding medications to the lifestyle helps patients maintain that weight by interfering with the weight regulatory system that wants to bring them back again. So now you're looking at 6 to 15% weight loss. So I'm going to wrap it up here with surgery, which I'm not a surgeon, but again, we have well-established criteria for referring patients for bariatric surgery, 35 and higher with obesity-related comorbidity, 40 and higher without. I think the state of California is way ahead of Oregon and other states where this is pretty much, in my understanding, a routine offering by most healthcare systems. And I think they have reaped the benefit of doing that. And let me just show you. Currently, there are 3 major primary operations that are offered. The first is the lap band, which, as you can see here, results on average about 10% weight loss, 10 to 15% weight loss, but has a high complication rate. So since we can achieve that with medicines and the higher complication rate, we actually don't recommend lap bands anymore. Instead, we recommend considering either sleeve gastrectomy, where the greater curvature of the stomach is resected and removed, or the gastric bypass. And you can see that the gastric bypass achieves a weight range long-term closer to 25 to 30%, whereas the sleeve gastrectomy is around 20% total weight loss. And lest you think that these procedures simply make the stomach smaller or cause malabsorption, I was telling Dr. Balmer that Dr. Bruce Wolf and I up here and many other people around the world, including Sweden, have been the leaders in understanding the physiology and the physiologic changes that these surgeries result in that improve the peripheral environment for the brain to allow it to be happier to body weight level. And I'm not going to go through these, but there's about 9 to 11 of them we've identified that occur after gastric bypass, and about 7 or so to 9 after the sleeve gastrectomy, that all converge and help reduce the caloric intake and maintain that reduced caloric intake long-term, along with changes in energy expenditure. So these are the real reasons why these surgeries are so effective. And the surgeons didn't design them that way, but they stumbled on that's why they call it metabolic bariatric surgery now, because these surgeries alter favorably the metabolic milieu for the body. Now, if you just look at diabetes alone, starting off with that, and this is a meta-analysis of randomized controlled trials comparing best medical therapy for diabetes versus bariatric surgery. And this is typically sleeve gastrectomy or gastric bypass, although one did include a duodenal switch and another did include the lap band. But these are randomized controlled trials. So these are patients who are willing to be randomized to best medical therapy or surgery, which is oftentimes hard to do. And as a meta-analysis shows you that all but one of these trials showed a favorable outcome in terms of glycemic control when you went through bariatric surgery. So hitting target, lowering A1C below 7% or 8%, whatever it was, reducing diabetes medications. The only one that didn't show a statistically significant change was the lap band, which I mentioned we don't do anymore. We don't recommend anymore. But let me just point out, this number down here is a 10-fold higher rate favoring the the bariatric surgery. This isn't a 1-fold. This is 10-fold better outcomes with bariatric surgery than best medical or weight loss program or best medical approaches to diabetes management. And this is a study that came out of the Kaiser Center, the Kaiser system, comparing cardiovascular and total mortality outcomes after bariatric surgery versus in 5,000 patients compared to a 3-to-1 or 15,000 controls followed over 7 years, showing a 42% reduction in MACE outcomes. 42%, that's better than you can get with statins and blood pressure medications. If you look at strokes, 42% reduction. What drugs can do that? If you look at all-cause mortality, 50% reduction. We got excited when GLP-1 receptors came out and showed a 12% reduction in cardiovascular in mortality with for diabetes. This is a 53% reduction. And then if you look, this is the study out of Cleveland Clinic with Stephen Neeson's group, 2,000 patients who underwent bariatric surgery, a 5-to-1 control group, now 11,000 controls, showing a 38 or close to a 40% reduction in 3-point MACE, a 60% reduction in chronic kidney disease and kidney-related outcomes, a 22% reduction in atrial fib, a remarkable 62% reduction in hospitalization rates for heart failure, and again, a 40% reduction in total mortality. So this is mirrored by every study that's out there in terms of reduction in cardiovascular event rates with and without diabetes, showing about a 50% reduction in cardiovascular endpoints. And if you look at total mortality, this is a study that just came out in Lancet of a meta-analysis of matched cohort and prospective control studies with 175,000 participants, 66,000 with surgery and 108 controls without surgery, showing about a 50% reduction in total mortality, even in patients without diabetes. If you want to just focus in on the male group, because typically those studies included mostly females, But this is the survival study from the VA looking at surgical bariatric surgery patients versus matched controls, 53% reduction in mortality. So the conventional wisdom that these surgeries are extreme or that they're too dangerous to recommend to patients. But the 30-day complication rates actually approaches, if not better than getting your gallbladder out if you go tomorrow and get a gastric bypass. And the long-term data shows that they're not dangerous. In fact, if you have a patient with type 2 diabetes with a BMI over 35, their outcomes from a cardiovascular standpoint, hands down, beats anything you can do for them with any other therapy. And if my contention is, if you're a provider and you're not talking about bariatric surgery to that patient, you're not giving them the full measure of the benefits that you have to offer them. So compared to lifestyle and weight loss medications, we're looking at 25 to 30% total weight loss long-term. So in summary, obesity is a direct and indirect contributor to heart disease. Weight management expands the your provider's therapeutic toolbox. And rather than think of anti-obesity medications and bariatric surgery as adjuncts to lifestyle, we need to start treating obesity like every other chronic disease where it's in addition to lifestyle. So you always start with lifestyle, but the majority of people, and if they manage to hit targets with lifestyle, they're lucky, and you can wish them well and have them keep doing what they're doing. But then you add in anti-obesity medicines or bariatric surgery. So what I'm trying to sort of convey is that we need to change our traditional approach, which has been intensive lifestyle management for obesity and diabetes and lipid disorders, followed by diabetes and lipid drugs, to an intermediate step where we consider options of weight management, initially or concomitantly, sometimes with diabetes and lipid-lowering drugs as well. So this can be an intermediate step like I illustrated. And I just want to point out two references that I think are resources that are good for people who want to find out more about this. The Endocrine Society Scientific Statement on Obesity Management came out a few years ago. And Endotext, that I'm one of the sub-editors on the obesity subsection. We have 28 chapters that are updated every 3 years. The most recent one on the anti-obesity medicines by Lou Aroney's group is brand new and probably one of the best around. So with that, I'm going to stop. I'll put a plug in for our own healthy eating cookbook by Tracy Severson, our dietitian. I think you're on mute, Eddie.
Okay, so we do need to quickly switch to our next speaker and postpone the Q&A until after Diana Alba's presentation. Dr. Shadadpuri, a quick introduction, please.
Sure. I would love to introduce the dynamic Dr. Alba. Thank you, everyone, for giving oodles and oodles of information on COVID and obesity. Dr. Alba is our assistant professor of division and a specialist in endocrinologist from University of California, San Francisco. She's American board certified in internal medicine and subspecializes in endocrinology, diabetes, and metabolism. She's going to bust another one of her myths. Her primary research is focused on both obesity and diabetes in order to find ways to reduce deleterious effects in individuals in vulnerable populations. One of her researches that's sponsored by Robert Wood Johnson Foundation and American Diabetes Association focuses on individuals of certain ethnicities who are prone to developing obesity-associated metabolic diseases despite having a low group level BMI. So welcome, Dr. Alba. Can't wait to hear you. Please take on.
Thank you. Let me share my screen first. Okay, can you all see my screen?
Yes.
Great. Okay. Great. So thank you for having me. I have no disclosures. I might need to skip a couple of my initial slides for the sake of time. And Dr. Purnell already covered a lot of this, but the main point of this slide is to show you that we do consider diabetes a chronic condition, a disease like any other, like hypertension or diabetes, and that comes into play when we talk about treatment. So for a lot of the studies that have done and a lot of the data that we have in Dr. Purnell in review, we talk about definitions of the BMI using, definitions of obesity using BMI or the body mass index. And this is just a mathematical ratio taking into account someone's weight and their height. And so for many years, we have used kind of the same cutoffs, a BMI of above 30 for obese, between 25 and 29.9 for overweight, and then anything above 18.5 and below 24.9 is considered normal. And I'll talk more about why BMI is not the best tool to screen people for obesity, specific in certain ethnic groups. We also have definitions for different grades or categories of obesity. So we have grade 1 to 3, with a BMI above 40 being extreme obesity. And a lot of you have seen this map or a variation of this map showing the prevalence of obesity in the US. And this is what we consider that obesity has actually become an epidemic. So right now we have 35% of our population in the US, and these are adults above the age of 20 are considered to be obese, and then 70% of the population is overweight or obese. And unfortunately, we're seeing really high numbers on our children and adolescents also. So now I will look at the prevalence of obesity from the 1960s, kind of looking at this graph. Until recently, we have a really interesting pattern. There's been an explosion of obesity, particularly severe obesity. And so this is here looking at the percentage. And so there's been a doubling or tripling or more in certain categories of severe obesity. So again, BMI above 40. But overall obesity has increased. Overweight has been stable, as shown as this line over here. And so one question that we often get asked is what is actually going on? And so here's an even more interesting illustration analysis of BMI data showing that the biggest percentage increase in body mass index is in the highest BMI categories. So there has been about a 40% increase from 2001 to 2010 in the total BMI greater than 30. But it's really the BMI greater than 40 and actually 50 that has increased most dramatically. So when we look at the diseases that are associated with obesity, like diabetes and heart disease, as well as other forms of vascular disease, like stroke, for example, we recognize that that's really where the epidemic has actually occurred most fully. And so we look at the diabetes numbers from 2015, and we see that about 9.5% of the population, or about 30 million people with type 2 diabetes. And again, this is most prevalent in the South, as well as heart disease is the same thing, most prevalent in the South. And so we wonder what's going on here, right? Is it just diet? Is it something else? And we really know at this point that it's multifactorial. There are many different factors contributing to this trend. And all of them add up to worse health, particularly for people in some parts of the population, unfortunately. And so now when we look at our concerns about obesity is that there is an increase in the risk of dying and people having disease that cause you to become ill, right? And so when we look at what is causing this, obesity has been associated with many different diseases or illnesses. And so if you look at ischemic heart disease, stroke, diabetes, we also talk about respiratory diseases such as asthma. When you have a higher BMI, and this is a very wide range, right, between 25 and 50, you do have an increased hazard ratio for most of them. And what's also really interesting is when we actually look at the overall picture of life expectancy, there has been a number of meta-analyses. There are particularly two from 2009 that actually have shown that the body mass index that is elevated can lead to a reduced lifestyle expectancy. So a BMI between 30 to 35 can actually result in a reduced survival between 4 years, and a BMI between 40 and 45 actually reduce it by 8 to 10 years. So that's pretty significant. And that's not, there is really interesting data show you that if you also have someone who's a smoker, then the numbers are even worse. So very quickly, because Dr. Brunel covered a lot of this, but what causes obesity? And we know it's not something as simplistic as a simple energy balance. We know that the whole picture is still very unclear on how obesity develops. It is really to involve an integration of social, behavioral, cultural, metabolic, and genetic factors. And we now know that the behavior and environment appears to play a large role of the development of that obesity. Especially we're looking at people from a specific ethnic groups when we have what kind of quality of food they have, what access to food they have, access to parks and things like that to be able to exercise. So energy imbalance, again, arises when you have more calories that are consumed, and this is not equal to the number of calories that the body is using. And what we also know is that if we put all of this kind of together, we have this positive caloric balance or imbalance, and then you have a sedentary lifestyle, you have genetic predisposition, you have environmental factors. And so we now have physiological evidence linking obesity to the increased prevalence of many diseases, right? So type 2 diabetes, cardiovascular disease. And so we think many of the problems, for example, asthma, we believe that there is this pro-inflammatory environment of obesity, and is part of what triggers asthma in some people. When it comes to cancer, we also know right now that there are more than 11 cancers that have been associated with obesity, and they run the gamut from breast to cervical cancer, colon cancer, esophageal, pancreatic, kidney, as well as heart disease, dyslipidemia, and type 2 diabetes. And so this accounts for the majority of the mortality and morbidity that we see with obesity. However, we know that fat is not fat in the same way. So all fat is not the same. And so for the past number of years, there has been an enormous interest in looking at this visceral fat, the fat inside the abdomen, as opposed to subcutaneous fat. And so we now know that there is, this is not solely what's causing the kind of rise of obesity, but we also know that where we have the position of fat is actually how it impacts the organs locally as well as systemically. So fat around the pancreas, for example, seems to have an impact on beta cell function, and fat around the heart seems to have an effect on cardiac function. And so it's really understanding how these fat depots interact locally and systemically with organs. And this is what is helping us better understand the risk associated with obesity. So for example, subcutaneous fat, we have both femoral fat or gluteal fat, and then this superficial fat right here has been shown to be kind of considered more like low risk, or in some cases reduced risk of disease that we associate with obesity, whereas fat inside the abdomen or the visceral fat or mesenteric or the pancreatic fat has been shown to be an increased risk. And so here's an interesting view of this. There are systemic effects and there are local effects, and different fat depots have these effects, right? So we have the pancreatic fat, we have your subcutaneous fat, you have fat around the kidney. And so you can read this on your own. There's really interesting data on this, but I'm not gonna go into detail, but you can see that, for example, again, pancreatic fat in particular seems to be associated with obesity and with factors that lead to type 2 diabetes. There are some that are associated with insulin resistance, with metabolic syndrome, fatty liver, visceral fat is associated more with inflammation and insulin resistance. And when we add them all together, it leads to cardiovascular disease, type 2 diabetes, and many of the other metabolic consequences of obesity. So some of the more interesting studies that I have seen recently have to do a little with the fat surrounding the myocardium and its impact on inflammation, cardiac inflammation, and also the fat around the kidney. So some of the studies have shown that actually fat around the kidney, which is actually within the kidney capsule, puts a lot of pressure physically on the kidneys. And so that leads to increased blood pressure, right? So that seems to be pretty simple. And so then with weight loss by lifestyle modifications, medications, or bariatric surgery, this can actually result in reduced in blood pressure, right? Because it's going to be a lot easier to perfuse the kidneys without that external pressure on the kidney. That's just one of the many reasons of why the blood pressure might decrease with weight loss. But again, the point is that in some cases we see physical or mechanical causes, but in the majority of cases, we actually have hormonally mediated by increase in inflammation, insulin resistance, oxidative stress, and other factors that are associated with obesity. Just to underscore the association between abdominal obesity, metabolic syndrome, and cardiovascular disease. So we have data also from this study, the HOPE study, showing that if you look actually at a better measure than BMI, still very crude, but we're talking about waist circumference. And so when you think about it, if you're measuring subcutaneous fat, deep subcutaneous fat, visceral fat around your waist, in some people, this might be different than somebody else, depending on where the fat is accumulated, right? And so there is an increase in cardiovascular death, myocardial infarction, and all-cause death with an increase in graded, or when you have graded waist circumference. And so they divided in tertiles, and the higher tertile, you're going to have more death, BMI, higher BMI rates, and then cardiovascular disease. So this is something that we should be thinking about and doing in our clinical practices. In waist circumference, importantly, modifies BMI index. And I'll talk more about BMI and how it's not a good way to assess complications related to obesity. So what is very powerful about obesity is that you get multiple organs and multiple hormones, and Dr. Purnell covered a lot of this already, that can lead to these problems, right? So for example, for complex problems like cancer, we know that inflammation is associated with cancers, and this pro-inflammatory environment can actually lead to cancer development. And again, in obesity, you have a lot of these pro-inflammatory hormones. And so we have hormones like estrogen, for example, which we know that if we have higher levels of estrogen associated with breast cancer, and also higher levels of insulin, which we can see from insulin resistant and greater insulin production to try to reduce glucose levels. These all have been associated with breast cancer. And so right here we have 3 hits that can all not only cause breast cancer, but for someone who already has a genetic predisposition to breast cancer, it could lead to a greater tendency for a tumor to spread, for example. And so when it comes to hypertension, dyslipidemia, type 2 diabetes, tendency for thrombosis, cardiovascular disease, arthritis, and inflammation, is really clear that an increase in body mass fat is not good and will promote the complications that we associate with obesity. And so, for example, adiponectin is a hormone that comes from adipose tissue, but as adipose tissue stores expand, adiponectin levels are suppressed. And as a result, there is a higher risk for cardiovascular disease. And so adiponectin seems to be preventive or like protective for type 2 diabetes and heart disease. But as fat mass, especially visceral fat mass, expands, you get lower levels of adiponectin. So, a lot of really interesting work being done that is helping us understand how this picture might actually fit better together. So another example, this is a look at C-reactive protein and fibrinogen. C-reactive protein is a non-specific marker of inflammation. It has been associated with high risk of cardiovascular disease, and fibrinogen is associated with clotting. This is part of the clotting cascade. And so in this study from 2009, they look at subjects who were considered normal or have a normal BMI, and that was their reference range. And then they look at those who are overweight, looking at BMI between 25 and 29.9, and those in different classes of obesity. And so you can see there is a steady rise with an increase in obesity class. And so here there is a 7-fold increase, and we see a 9-fold increase over the range between overweight and obesity. And this can help us to have a little more insight, to give us insight into why higher levels of obesity are actually associated with so much mortality and morbidity. And I think Dr. Purnell covered a lot of this. So obesity is expensive. We have another obesity rates increase of $300 billion. And these are 2010 values. And this is higher depending on the obesity class. And so if you look at a curve like this, you can see that the total expenditure increases dramatically as you go up in your BMI range. And also if you look at some people who have or don't have type 2 diabetes. And so once you begin to go above BMI of 30, there is an increase, kind of like exponential increase in the costs of medical expenditures. And so for example, if you have someone who has a BMI of 47 and has type 2 diabetes, we're talking about $25,000 per year. So going back again to BMI, why it's not a great marker of obesity and obesity-related complications. So most of the type 2 diabetes in patients is in people with obesity, relatively less. Those who are considered to be overweight but are usually standards of BMI. and then less than those who are normal weight or underweight. Is it possible to have diabetes if you're normal weight? Absolutely, but you're far more likely to have it if you are in an obesity category, right? And so again, you have seen these maps many, many times before. And so as the prevalence of obesity here on the top from 1994 to 2015 have increased, we also see a mirror by the increase in type 2 diabetes. And so we see the overall numbers, and there's been a doubling in obesity over that period of time, and we have a close to 30% increase in type 2 diabetes. But it's not that simple. We, however, now know that there's significant ethnic and racial differences when it comes to diabetes prevalence, especially when we use BMI-based approach for screening. So this is data from the distance studies, a prospective cohort from Kaiser. They have a diabetes register that has about 64,000 patients, and this is from 1996 to 2006. And so what they did is they look at their data, they standardize the diabetes incidence rate per 1,000 person years. And then they look at the incidence density of new cases of type 2 diabetes divided by ethnicity based in the 2010 census. And so what they did is they look at all of the Asian groups, they look at Chinese, Japanese, Filipino, they added Pacific Islanders. And if you aggregate all of the Asian groups, either as all Asians or all API, and LPI is all Asians plus Pacific Islanders, you see that the incidence of diabetes is significantly higher in these groups compared to the white population, right? What's also interesting in this study is that they went back and actually look at the BMI from these groups, and these are all adults over the age of 18. And they look at the BMI of those people with no diabetes, the new incident cases that I just showed before, and then prevalent diabetes. And as you can see in the Asian population, their BMI is significantly low in all of the different categories, right? So the Asian groups have lower BMIs, but have significant incidence of type 2 diabetes. So if we also look at the NHANES data, this is not only true for Asian Americans, it's also true for Hispanic. We have a high percentage of people who are unaware of a diabetes diagnosis. So looking at NHANES data, we have about 51% of Asians and 49% of Hispanic people who are unaware that they have diabetes because we're actually not screening them early enough for a lot of those cases. And so the American Diabetes Association, the NIH, the National Institute of Health, and the Center for Disease Control have all recently acknowledged that Asian Americans should be screened for diabetes at a lower BMI. And 23 is the number that was chosen based on a lot of the data that has shown. And I think a lot of you have seen these screen 23 ads. And so why is that, right? You might ask, why do Asians have a higher risk or a lower BMI? Well, this is a study done over 25 years ago on healthy volunteers in New York City. And what they did is they compared the BMI to the percent body fat by DEXA scan. And as you can see, even though we know that BMI on a macroscopic level is a fairly good surrogate for body fat estimation, there is definitely a lot of shortcomings when it comes to body composition in people from different ethnic groups. And thus, this is what it's showing, right? So even though both the Asian males and the Asian females had lower BMIs, their percent body fat was actually higher. And so again, BMI identifies individuals at a higher risk for cardiovascular mortality and other diseases, but it really underperforms as a risk predictor and a sole guide for our clinical decision makers when we're thinking about other ethnic groups. And so if we look at other studies, this particular study was looking at a proportion of subjects BMI with metabolic abnormalities. They consider metabolic abnormalities if you have more than 2, so low HDL, high triglycerides, elevated glucose or being on glucose, lowering medications, or hypertension. And so in this particular multi-ethnic study using the Masala study and the MESA study with different ethnic groups, so they had South Asians, they had whites, Chinese Americans, African Americans, and Hispanics. And so what we see here is in this normal weight, and they use a BMI less than 25 to be considered normal weight in this particular study. But if you look at this particular group, so these are the metabolically abnormal, you can see that between 21% to 44% of people with what's considered normal BMI have actually metabolic abnormalities. So we cannot tell someone who that they're healthy just because they have a normal BMI. And what's also really interesting here is that the proportion of metabolic abnormality really varies between the groups, right? So according to race and ethnicity. And so the lowest one was for the white population, the highest one was for the South Asian population with 44% of the people. And so remember that when you see a patient that is South Asian, you should remember that 44% of them can have metabolic abnormalities with normal BMI. This is another really very interesting data. This is from the UK. They had 1.5 million people, and they wanted to look at the incidence of type 2 diabetes based on BMI. And they, so the incidence of type 2 diabetes for a BMI of 30 in the white population can be read off by this line right here, and the intersection with this dotted line, right? So you have a BMI of 30. But when they did age-adjusted and sex-adjusted BMI cutoffs in different minority groups, so they have Black, Chinese, Arab, and South Asian, you can see that the BMI cutoff changes significantly. So you have about 28% or 28, sorry, BMI for Black, about 27 for Chinese, 26 point something for Arab, and about 24 for South Asians. And this figure shows the BMI cutoff for Black ethnic subgroups and South Asian subgroups. So you have Black African, Black or other, Black Caribbean, Indian or Nepali. And again, we use the cutoff of 30 for obesity, and that's what have been used for many, many years. But as you can see, the cutoff changes significantly if you actually look at Bangladeshi people, or people from Bangladesh, sorry, the BMI is actually closer to 21. So in the Latin population or the Hispanic population, there is a lot of data out there. The problem is that we know that Hispanic population varies significantly. So you have people from the Caribbean, you have South Americans, you have Mexicans who are more indigenous. So it's really hard to find a specific study that kind of combines everyone. But this is a really interesting study from Dr. Nieto Martinez. And this is looking at people from Venezuela, so South America. They set to define the accuracy of BMI in detected body adiposity. And so they measure BMI, they also measure percent body fat by impedance, now by DEXA scan. And so as you can see, the percent body fat to define obesity and not BMI, if you actually use the percent body fat and not the BMI, there are 21% of people who are categorized as non-obese when in fact they fit the definition of obesity. And they use the definition of obesity by percent body fat using the WHO. So sorry, more than 25% for men and more than 35% for women. And they actually went back to look at the NHANES data, so data from the US, and similar proportion was actually found also on the NHANES. So the percent body fat was actually a better way to assess obesity on who actually fit the diagnosis of obesity. And so in this particular study, and Dr. Nieto Martinez have been advocating for also using a BMI of 27.5% to actually improve the detection of obesity in the Hispanic population. And to show you that how we're misclassifying people by using BMI, this is on the basis of the National Health Interview Survey. They actually reported that using the current BMI thresholds of overweight at 25 and obesity at 30, the proportion of Asian Americans who met the criteria for overweight and obese were only 29% and 7%, which is actually way significantly low compared to the general population. And so what they did here is you have Asian Indians, Chinese, Filipino, and other Asians. And so if you use the WHO Asian BMI standards, so BMI 23 to 27.4, as opposed to 25 to 29.9, they show that you're missing 12.6% of the population by doing that. Same thing if you're using the categories of obesity, so you actually use the general BMI above 30. But if you actually use 27.5, if you look at the numbers, you are missing 9.9% of the population by using the BMI of 30. And so again, as I mentioned before, Asians and Asian Americans have substantially higher levels of adiposity at the same BMI as non-Hispanic whites. And so they also develop cardiovascular risk at lower levels of BMI. And so for those reasons, WHO expert consultations are recommending a lower BMI threshold for overweight and obesity among Asians. However, what we also have to keep in mind is that we are also overdiagnosing obesity in some ethnic groups. So people who are muscular but do not have excess adiposity have higher BMI, which allows a number of people to be inappropriately diagnosed as obese, correct? So just in his data, Borgsar and Coley compare BMI and total body fat and percent body fat measured by bioelectrical bioimpedance. And so what they showed was actually that on average, Black females have 3.6 kilograms more fat-free mass, so muscle, bone, and fluid than white females, and that Black males have 1.3 kilograms more of this fat-free mass. And so again, using BMI criteria of a BMI of 30, you have about 34% of Black women who are classified as obese. But if we actually use the percent body fat cutoff, so 41% for women and 29% for men, only 26% of them actually fit that criteria of obesity. So you have your, given the wrong classification for about 8% of that population. And same thing for men. So if you use the BMI cutoff of 30, you have 19%, but if you use the percent body fat, it's only 13%. And so overdiagnosis of obesity is also important to know it's not limited to Blacks. There was another group that found that the same level of body fat and same age and sex in the Polynesian population. So we're, by using BMI, again, we're miscategorizing a large number of people. So why does it matter, right? What's really important was the clinical point here is that all of the shortcomings with BMI have led to many organizations to actually include, such as the ADA, the American Diabetes Association, the American Association of Clinical Endocrinology, to actually propose a complication-centered definition of obesity in people with BMI above 25, right? So instead of 30. And so it's important to note that right now, if you look at this table from the American Association of Clinical Endocrinology, usually we were looking at being overweight, having a BMI of 25. Oops, sorry. So if you can see here, they're actually considered 23 for certain obesities, or actually we're using waist circumference below specific cutoffs that have been published. And then same thing for obesity. So above 30, but in certain obesities is a BMI above 25 or 23. And then they reclassify the different stages of overweight, obesity stage 1, 0 to 2. So why does it matter? Well, so now that we see someone with a lower BMI who might be South Asian or from Bangladesh, we know that we need to start screening early on for type 2 diabetes, for PCOS, sleep apnea is another thing, asthma is something else that we have to keep in mind as clinicians. And that also comes into play when we're thinking about therapies or medication. So right now, the cutoff for medication for weight loss is actually a BMI of 27. When it comes to bariatric surgery, the cutoff is a BMI of 40 or 35 with complications. But what's important to know is that in March of 2018, the Congress of the Asian Pacific Metabolic and Bariatric Surgery Society actually set new set points for BMI, and they actually decreased the BMIs by 2.5 for the Asian groups. And so now they could recommend surgery for a BMI above 37.5 instead of 40, or above 32.5 instead of 35 for those who have type 2 diabetes. And actually there's really interesting data where they have been doing surgeries on people with BMI of 27.5 with very difficult to control diabetes to show that it significantly improves their diabetes. That also means that there are a lot more potential candidates for bariatric surgery among this particular population, but that's definitely something to keep in mind. And maybe the numbers and the cutoff for medications might be changing in the future. So my main take-home point is that in patients from certain groups, from certain ethnic groups, we have to start screening early for many of the obesity-related complications, even if we don't consider that they are obese, or even if we don't think they look obese, but they might have this extra adiposity, visceral adiposity that we have shown that increases the risk for a lot of complications. So in summary, the prevalence of overweight and obesity in the US is higher than ever before. Being overweight or obese substantially raises one risk for morbidity from many diseases. BMI and actually waist circumference are correlated with body fat and actually can predict the risk for disease. And we should be thinking about adding waist circumference if we don't already as a way to modify the BMI. Because reliance on current standard or the universal BMI of or threshold of 30 leads to missing excess adiposity in a large number of the population. And this problem is particularly relevant for populations of East Asian and South Asian. And again, significant differences exist in obesity among different racial and ethnic groups. And with that, I'm gonna end.
What a great presentation, and so fast, Dr. Alba. And I know that you had a presentation or a clinical situation in just a few minutes. So let's see, we had quite a few questions. One was, do you believe that intermittent fasting works?
I can take that one. There is really interesting data about intermittent fasting. I particularly think that it works because a lot of people reduce the number of calories that they're eating per day. And so there is I think there is a study from UCSF, it might be more in adolescents, where they look at this and they show that it does work. People lose more weight, but they also look at the caloric intake and it was significantly reduced. I know there is also some data that says, can't remember the specific details, but they compare people who are intermittent fasting and they have different caloric intake. And they said the reduction or the weight loss was more related to the reduction in insulin levels, right? So if you don't have the spikes in insulin that you have throughout, like, because you're eating multiple meals per day, then that's what's actually what leading to the reduction in weight loss. But particularly, I believe is more people are eating less because they are restricting their eating to 8 to 9 hours per day. I don't know if Dr. Purnell has another point of view.
Yeah, this is a question that's been going on for a long time. In my read of the data, to kind of look at the studies that I've seen over time, if you're looking at just weight loss and caloric restriction, you have better metabolic outcomes initially with intermittent fasting, but the end result in terms of total weight loss is about the same as if you don't intermittent fast. And so both of them are kind of what I say equally lousy in terms of sustained long-term weight loss. And it's actually harder for us humans to intermittently fast, a lot of us at least, because you get hungry, those biological signals I was talking about. So you become preoccupied with things. So you might have some short-term metabolic health benefits that don't translate into long-term things. So it's kind of one more thing along the line of a million other things that people have tried in hopes of finding a cure for obesity that really runs into the physiology.
Just looking at the maps of the increase in weight and increase in diabetes across the decades, it's striking that perhaps there's an environmental factor beyond what we've heard about today. I do wonder about the hormonal environment with such a massive increase across the population.
There is definitely data. I'm not really up to date in a lot of that. I did read a study because people are trying to understand why in the South, the rates of obesity are way higher as well as type 2 diabetes. Obviously has a lot to do with the diet, but there was a study looking at the use of air conditioning in some of the chemicals that might be released from the ACs during the summer times. That's all I can tell you. I mean, I know there's a lot of groups looking at other environmental factors, but certainly we know that diet, access to food, like I think I mentioned, when you have people who are in lower socioeconomic groups, they don't have access to parks, right? They are not going to be able to exercise. It's not easy to say someone go and walk for half an hour. A lot of my patients here in San Francisco are like, it's not safe for me to go and walk for half an hour. So that's definitely a driver for a lot of specific minority groups.
I agree fully. What is quoted based on adoptee studies, based on twin studies, based on family studies, is about 40 to 70% of what determines our adult weight. So whether lean, overweight, or obese, is genetics. And that leaves anywhere from 30 to 60% environmental influence. So it's a combination of the two things. And Dr. Alba pointed out very nicely that the greatest rates of obesity are occurring in the people with the greatest BMIs. I mean, the trajectories of the people in high BMIs, those are the ones we consider to have the highest genetic risk. So they're responding to the adverse environmental changes in the strongest way. And there are thought to be endocrine disruptors and other things in the environment. But actually, a guy named Barry Popkin has been studying this in economies that are transitioning from third world to first world status for probably 30 years now, starting with China. And really has described a number of changes within the modernization of our environment that probably play a much bigger role than trying to look for the little contributions from, not to say I'm not minimizing them, but we don't want to look past the big ticket items. And so part of that has to do with modernization of our work environments, from working in fields to factories and now sitting in desks listening to lectures, to the rise of the processed food industries. And I think about, we were talking about intermittent fasting, and if you actually, I've been doing a lot of feeding studies, looking at changes in hormonal secretion and body weight for a long time now. And almost universally, you can pick your diet. Well, we were talking about keto diet, you could talk about a low fat diet, you could talk about a low carb diet, and they all on average cause some weight loss. And people nitpick whether one gets more weight loss or another, or maybe there's certain subpopulations that you can do that. There's only one diet that shows weight gain. And that was Kevin Hall's study recently, where he looked at same foods in a whole food category that were then presented to patients and allowed to eat ad libitum in an ultra processed environment. So do you eat your food as a salad and meat and things like that, or do you have a hamburger? So macronutrients are taken out of the loop. And it was the ultra processed diet that caused weight gain. That's the only diet that does that. And it recapitulated what's happened in our society since the 60s in terms of processed food intake, sugar added beverages intake, and couple that with the reductions in energy expenditure during these vulnerable times in our lives up until the age of 60. And there's plenty of opportunity for environmental exposures to allow expression of these genetic potentials seen in every country around the world. Oh, and someone asked about my sister is a pear and I'm an apple, or vice versa. And if you look at those same family studies using CAT scans and MRIs for visceral fat accumulation, they also run in families, and using twin studies, about 60% of what determines where we distribute our weight is also thought to be genetically determined. So the bottom line is, unfortunately, we tend to look like our parents when we get older, whether we like it or not. But you don't ask for the weight to go around your middle. It's not a beer belly. None of that's true. And Dr. Alba hopefully will back me up on that. This is stuff that happens physiologically to you that, it's a fascinating area again.
Mm-hmm.
I have a general question as a cardiologist interested in cardiovascular disease prevention. Do we have data on the or evidence on childhood obesity and how that affects this ethnic groups and is that something that we should tackle? We usually hear the usual thoughts about that chubby kids will outgrow their obesity with their growth spurts and then become normal. Do we have data on this? It seems.
Yeah, I don't think that's quite the case. So we where I do my obesity clinic, I see a lot of Hispanic patients, and I always ask about family members, children. And to be honest, I feel like a lot of my patients, their kids are obese. And so it goes back to environment and their diet and how sedentary they are. So it's also cultural. I feel like a lot of people, Hispanics, kind of express their love by eating and food and offering food. And so for them, having a kid who is a little overweight or even obese is healthy, is normal, right? I mean, that's their culture. And so, and we see it also in the African American population. I mean, a lot of them, they grow up eating a certain way. That's the food they're exposed to. If they have a low socioeconomic status and there is not a lot of money, they might grow up eating McDonald's or junk food. And so I don't think if a couple of them might be lucky and they start exercising and they're very active in high school and they lose the weight. But I think for the most part, there's a lot of data showing that that obesity kind of translates to adulthood. So a lot of them are going to become either overweight or obese when they're adults.
Yeah, there's certain weight trajectories that are seen in early childhood that are better predictive of adult obesity and complications. And that's called the rebound adiposity around the time of 2 to 5 years of age. And if you have obesity in that category, there's a famous study by William Dietz back in 1997 that looked at this. One of the best predictors of whether you have adult obesity is your parental obesity, as Dr. Alba said. If you meet criteria for obesity as a child age of 5 years of age, and one of your parents is obese, then you have a 3-fold increased risk of obesity in adulthood. If both parents have obesity, it's a 15-fold increased risk for obesity. So it's not guaranteed you're going to grow into your weight by any stretch of the imagination. And the earlier the onset of the obesity, the less and the more parents you have, kind of a gene dose effect, the more likely you will become obese as an adult.
Could you elaborate a little bit more on the twin studies? I think that is so important to tease out what is environmental, as in generation to generation habit forming, if the twins are separated.
Yeah, well, actually, probably the better study was, I think the twin studies kind of bring them up in the same environment, but if they're identical versus fraternal. But one of the better studies was out of Denmark a few years ago that looked at this. It was called the Danish adoptee study, where they took kids because you could follow adoption records in Denmark and look at adoptee parents versus biological parents. And they followed the children out to their 20s and 30s and said, what was predictive of the childhood or the young adult obesity rate? Was it nature? Despite the fact they were adopted into parents who were thin, did they look like their biological parents? Or was it nurture? Was by having them adopted in, from a kid from 2 thin parents into a household where the parents were obese, did they look more like their adoptee parents? And so when they looked at the relationships, they found no relationship between the young adult weight and the adoptee parents, suggesting that the environment they were growing up with had a very low to no impact on their young adult weight. But they did look, the association was positive and strong with the parents that they had been, biological parents that they had been adopted out from. So that's the adoptee study. But if you look at the twin studies, the power of the twin studies is that both twins are brought up within the same environment. So if it's environment, then whether they're fraternal or identical, they should look the same. But in actuality, there's a very strong relationship between identical twins and their adult body weight. But there is about a 60% agreement in the relationship between the fraternal twins. So obviously there's some agreement there. And so there is a very important influence of environment on that, but that's where that, 60% comes. That's one of the pieces of data shows that relationship. And that's true for visceral fat as well. That's true for dietary weight loss and weight gain in overfeeding studies. So it points to the biology, the inherited biology being similar between the twins.
Dr. Balmer, did you have some cardiology questions you wanted to pursue?
Well, first of all, I wanted to thank both speakers for excellent presentations. That huge amount of data you went over and presented to us, much of which is new and certainly intriguing. Jonathan, you implied, which was a little bit disappointing to me, that once we set our set point for body mass higher, it's very hard to get it down. You can move within a range, but your range is now a one-way direction and you're set higher at that point. And to really break out of it, in addition to lifestyle, you need medication or surgical interventions at that point in time. I think that's obviously true that we've seen, and that's our experience. And I think it perhaps helps us to know that there's something else fighting weight loss in those individuals, and just re-emphasizing lifestyle may not accomplish what we really want. But within the range, a drop in weight has important cardiovascular implications. You also talked about GLP-1s and how they reduce risk, et cetera. If you look at another, quote, early diabetic medicine, SGLT2s, those are associated with about a 5-pound weight loss as well. Is that weight loss because they help reset the parameter, the CNS weight loss parameter, or can it be explained entirely by the loss of glucose calories in their urine at that time?
So that's a very good question. And I don't know that we know the real answer to it. But I'd say that you do pee out your calories, but that's more so when you have high glucose levels. And we know that there's still some benefit even at when your A1C approaches more of the normal range. And again, I think it was Kevin Hall's group looked at this elicits an increase in food intake in participants when you do that. But you do have a little bit of a osmotic diuresis too. So you have a little bit of plasma volume loss. We do know there are SGLT receptors or transporters within the brain. Now they're not, I think they're more the SGLT1s, but I don't think any of these drugs are considered completely homogeneous in terms of their action. So even though you could theoretically calculate that the calories that are increased in food intake replaces those calories lost in the urine, I personally believe there's a small effect in the brain probably going to these drugs. But I've been surprised by the myriad of benefits of the SGLT2 inhibitors. I thought it was the stupidest idea ever when I first heard about it. And then all of a sudden you've got renal protection, you've got heart failure, even in patients without diabetes. I mean, it's like a miracle in some ways. So I wouldn't surprise me if there's something else going on there that we don't know.
Yeah, and their cardiovascular mortality reductions are significant as well, as high as 38% in some of the trials, including all-cause mortality. The other question I had was, is there an anti-ghrelin agent or treatment? Because if we could get rid of our ghrelin, which is telling us to eat after 2 hours, et cetera, I might go 4 hours or 6 hours or something before I thought about picking up the next bit of snack.
Well, these medications do dampen down the ghrelin signal in addition to amplifying the fullness signals. It's a very good question again. And there have been a number of companies, including Lilly, who first sort of went after ghrelin antagonists. But what we probably know is we don't know everything, and which means there are probably other orexigenic hormones, which is the hunger-inducing hormones besides ghrelin. And we know there's at least one that comes from fat tissue as well. So in the knockout models, it doesn't do as much as you would hope it would in terms of improving body weight. But I do know that there is so the interesting thing about this is that this is a very unique hormone. It requires an 8-carbon fatty acid attached to the protein to be active. It's the only hormone that's like that. So without this fatty acid, you don't have an active hunger-inducing hormone. And this is mediated by a very specific lipid transfer enzyme called GOAT, of all things. Ghrelin octanyl acetyltransferase. And there are inhibitors that have been designed against that. So you can still create the protein, but you have an inactive hormone. And are in clinical trials that I know of. I don't know the outcomes on them, but I would suspect that it works, maybe not as much as you hope, because there are probably other, as you imagine, there are probably other redundancy factors that are built into the system that prevents, even in the absence of ghrelin, from completely eradicating all hunger.
So
Thank
from a
you.
public policy perspective, what do you think of having walking desks, treadmill desks?
Well, before I answer, Dr. Alba, why don't you were about to say something.
Oh, I had a question for you about the ghrelin. Because if I'm not mistaken, years ago, there was some ghrelin, like there were some medications that were developed for animal studies for ghrelin, right? And I think they worked. They actually were able to prove that they block ghrelin, but there was no there was no weight loss. And this was all animal studies, like back in the 70s, maybe. So kind of going back to your point that we're obviously missing something else, because it's not just the ghrelin, because the animal studies showed that it worked, it blocked ghrelin, but there was no weight loss.
So to answer your question, Hattie, so this is my opinion. I'm not an epidemiologist. I'm not a policy person, but I like to work with people who are. And we, if you look at non-exercise activity thermogenesis, or NEAT, so it's the activity that we do when we're not actively exercising, allows us to burn off calories. That is a very malleable, responsive system that our bodies have. So that means that you can literally go out and run 2 miles one day and 4 miles the next. And in the time where you're not running, you'll make up for those extra calories burned on those extra 2 miles. So your body is able to down-regulate itself when you're not exercising to conserve calories in terms of if your ultimate goal is weight loss and sometimes improving the cardiovascular fitness. So we really, if we want to, we've got more and more data that shows that the stuff you do when you're not exercising, like less time spent in sedentary behavior, more time spent walking, those sort of outcomes studies are showing benefits on health. But I think, from a policy standpoint, if we want to really prevent obesity, because, I wasn't trying to be nihilistic, Dr. Balmer, because that's the same way we treat diabetes and heart disease. We don't cure diabetes in the vast majority of people. We manage them, and we understand it's a progressive disease. So we not only start with metformin, we're eventually going to give them 3 or 4 other agents as well. So if we really want to do something about diabetes, we really want to do something about obesity, we want to prevent it from happening in the first place. And so the environment has to change in many ways, but you're running up against things like how we build our buildings, where we put our stairs, are they safe? How you build your campuses for your businesses, how you build your cities. And there are a lot of competing interests along that line. The less active we are during the day, the worse it appears to be epidemiologically for our society. And you see that in China, you see that in India, you see it all these transitional economies where factories and call centers are replacing working in the fields. So it makes sense. And if we waited till we had proof that this was the case, we're going to be several generations down the road.
So I see Dr. Emmons is going to need to run, but he's asking Dr. Purnell a question. So Keith Emmons, longtime leader in the Right Care Initiative, asks, for thin diabetics that cannot lose weight to better their A1C, will the 2 drugs that you mentioned today improve A1C?
It's a very good question. I don't know the actual data on the non-overweight, non-obese patients, but I do look at them fundamentally, and Dr. Alba can weigh on this too, as primarily having a insulin secretory defect that, despite, unless they have lipodystrophy, is resulting in a impairment of insulin secretion. So, the GLP-1s certainly augment meal-related insulin secretion or glucose-related. So I would imagine, but I don't have the actual data that they do. SGLT2 inhibitors, maybe, I don't know. Dr. Alba, do you know?
She just had to sign off a moment ago. She was going to go do a procedure. So,
Okay.
Excellent discussion today. Do any of our leadership want to ask further questions, or shall we announce our next meeting?
Patty, just a quick comment. It's funny, Jonathan said that about geographical influences. In the Gulf, we have about 1/3 of the women and about 1/4 of the men who are overweight, and half of them have impaired glucose, fasting glucose. But policies, talk about policies, they put a 50% tax on all carbonated drinks and 100% tax on all the other sodas and things like that. And that somehow has lessened the uptake of all these things from the shelf. So when you talk policies and geographical influences, a lot can be done at many levels to increase awareness and change habits.
And that's great. People are oftentimes in policy look for the magic bullet. What's the one thing we can do that will have this magnifying effect and we don't have to worry about it anymore? But it's not one thing that got us here. It's multiple things. We can't write prescriptions for these for our patients. This really has to come from people who understand, market forces, economic forces, cultural changes, and really try to work against some of the things. Like I always say that the best thing ever invented and the worst thing ever invented was the Segway, that 2-wheeled thing.
Yeah.
That could really a remarkable engineering feat. But now you could get on this thing and you could ride for 2 blocks. Who needs that? I mean, put your Frappuccino on there and then you have something that really could be obesogenic. So we need to walk more. What I tell patients is to walk the first 2 blocks of your, not 2 blocks, 2 stairs, 2 floors of your building, and then take the elevator up. The elevators are definitely working against us as well. Anyway, it's not one thing.
Jonathan, you had, it was very interesting about childhood and, setting the point high. We had an example of that in California schools where we had obesity in children going up every year at a rapid rate of increasing overweight, obesity, and actually developing type 2 diabetes in school kids early on as a result of that. And so we put in an aggressive nutrition and exercise program that all school kids had to go. That was a dramatic change from before, with testing to make sure they were doing it and performing it. And what we found was we were very optimistic that we could stop the progression of obesity in kids. Once they entered school, they got no more obese as they went through the school year. But we could not reverse obesity, suggesting that once their set point was high, And our problem turned out to be front loading before they came into school. That is, we looked at our kindergartners coming in and preschoolers. They were already obese at that point. We couldn't ratchet it down or reverse it. We could, under the program, show that we could prevent further obesity in school, which was very reasonable considering we only had them for 6 hours a day. And the other 18 hours they were at home, and we had no control over their diet or exercise at that point.
Yeah, and I would contend that's a very important outcome, but not sufficient.
So Dr. Purnell, you were talking so fast, and you were talking about COVID and obesity. Now that we are in our after discussion, and we're up against this terrible reality of a significant percentage of all populations being overweight, at what BMI, just because that's what we seem to have the most information about, might it make sense to focus in on some preemptive action on that obesity that may have previously not seemed so urgent?
I'm sorry, I don't, is that, your question is?
So say you look at that J curve, which may no longer be relevant because of COVID. If COVID is attacking people more who have obesity, at what level of obesity? I seem to think that in the Mayo Clinic data, it's morbid obesity that we're really worried about with COVID. But you've probably looked at it a great deal more than any of the rest of us.
Well, actually, I have colleagues who have more so than I have, but I was just sharing with Dr. Baumer the study out of the Cleveland Clinic in the same population that I had shown you before. And those were people with BMIs of 30 or higher. There was 2,000 or so patients who went through bariatric surgery and 15,000 controls. And Steve Neeson went back and looked at their infectivity rate after surgery. So this all occurred before the outbreak. So after surgery, so the people who were in the post-surgical arena had lost about 30% of their body weight. And they looked at the incidence of infections, and they looked at the severity of their illnesses. They didn't have mortality from that, but they looked at, did they need to go to the hospital? Did they need to have oxygenation? And what they found was that the infection rates were the same. So whether they had lost weight or not, didn't impact whether they got the infection. It seems to be an equal opportunity infector. But the severity was markedly different. If they had lost the weight, it cut the severity in half. And so this, and the need for oxygenation in half. So it appears that obesity is primarily a risk for having a severe disease and mortality. So, those pictures we see of people in the ICUs really do show primarily heavy people kind of laying on their stomachs. And you can you predict that. And to me, what it says, I mean, certainly no one would have necessarily said right off the bat that, this would have happened. And certainly having obesity would make you worried that you don't want to get it, or you want to get the vaccination. And that's assuming that the vaccinations work for you as well. But to me, what that says is that, going back to the original discovery of leptin, this hormone from the fat tissue, which signals to the brain how much weight we carry, is actually from the cytokine family. And the receptor is a cytokine receptor in the brain. And it kind of makes sense that, the factor that mediates, reduced hunger would be maybe the same thing that makes us feel like we shouldn't eat when we get the flu or something. But it also has impacts on T cell immunity. And so we now consider having obesity to be an altered immune state. And maybe that's what's contributing to this worsening, infectivity rate, and also cancer risk that Dr. Alba mentioned. So, you have reduced ability to fight off cancer, especially estrogen or, dependent cancers or things like that. So to me, what this indicates is that, yes, we need to be worried about this. Is yet another reason why we want to try to protect our patients by not having them develop obesity in the first place, or if they do develop obesity, offering them effective therapies. But it also opens up this other avenue. What's going on in the immune system? The other disease process that gets a lot of sort of buzz out there is psoriasis. There are a lot of anecdotal stories about weight loss, large weight loss, particularly after bariatric surgery, with resolution of psoriasis, which is thought to be autoimmune too. So that would be my 2 thoughts on your question.
Yeah, and I think it's very interesting that obesity or central obesity is associated with increased levels of cytokines that we have in our body. And one of the problems that we see, not with catching COVID, but with hospitalization for COVID, is after the initial 1-week infection, our biggest problem is often cytokine storm.
Right.
That leads to further inflammatory damage of the cells. And a lot of the morbidity or mortality that we see is after 2 weeks, and it's often related to unrestrained cytokine storm. And perhaps a more obese individual has more adiposity to fuel that cytokine storm, and that may contribute to a higher mortality in those people.
Worth studying.
So I wonder if there shouldn't be some sort of research project that would look into electronic medical records for, say, people with a BMI above X. Probably, we've got a very large number of people with a BMI over 30, so it probably needs to be a different number to say, here in this COVID storm where we're really losing people who are, let's say, morbidly obese, maybe there needs to be a proactive effort around the new medications or approaches that actually would keep them out of the hospital. We don't have room for bariatric surgery right now, right? The hospitals are overwhelmed.
Yeah, especially if they've shut down their elective surgeries, and this bariatric surgery is considered elective. I know I have colleagues in the Obesity Society who have studied this and probably could answer it better, but it sounds like a great idea. And, and maybe even instituting preventative measures like with doses of steroids or remdesivir or other things earlier in people who test positive with a higher BMI. There might be room for that to keep them out of the hospital. Yeah.
I think we were all hoping that COVID was going to be temporary, but it doesn't feel like it now after Dr. Baumer's presentation this morning. Dr. Baumer?
Unfortunately, COVID has added about 5 pounds to each of us as part of the COVID slump of inactivity. And so it's almost a positive feedback. COVID enhances weight, weight enhances the complications or morbidity associated with the infection. So it's not the direction we want to go with that. And hopefully we can find ways of breaking out of that. But it's been a great discussion today. And we certainly want to thank Jonathan and our other speakers and participants for it. It really gives us a direction to go and goals. And Hattie mentioned, can we look at it? We actually have in what's most EMRs, we have an EPIC system, which is typical. It comes up right away on the patient profile, their body mass index, and can indicate it. We can recognize obesity easily with a digital platform system. The problem is, as Jonathan explained, the therapy for that and the correction of that is complicated in many individuals and difficult, and involves modalities that also have some side effects as well.
Can I just have make a statement on that, because this comes up a lot when I give these talks. And there's as I mentioned before, we don't teach weight management very well in medical school. A lot of practitioners haven't really been exposed to what I just I presented to this group. And there's still a general perception by, I would say, the majority of practitioners that this is a lifestyle choice by patients. So when patients come in, whether the intention is there or not, they feel shame about it. It becomes a traumatic experience for them. So that popping up of that BMI really is just another, I came in for my sore throat. Why are you talking about my BMI type of thing? It can then be a double-edged sword, and it can work against patients if the practitioner has nothing more to offer than to say, eat less and exercise more, because that just feeds into the narrative that this is their fault. But on the flip side of that, people who say, well, don't measure BMI anymore because the main reason why they say it is because you can't do anything about it. So if you can't do anything about it, you should just treat the comorbidities. But that's not true either. And it doesn't help patients who are suffering with a chronic illness or disease to understand what's going on. That doesn't remove the blame that they might have for themselves. It just kind of temporarily puts it to the side. So we need not only to have those markers of health, A1C, blood pressure, BMI, for guiding physicians and advanced practice providers, but we need those providers to also provide non-judgmental care that helps them to actually achieve the things that they want to do and that you're trying to tell them to do, which is eat less and exercise more. They need those tools to achieve that. And it's not just put back on them so they can then end up feeling shame or blame.
Yeah, with these
That's a helpful
new
reminder.
options and modalities, I think it's worthwhile going back to our healthcare providers and giving them education about the new understanding of obesity and the new options or treatments that are available for it, because this is all relatively new, other than phentermine and that agent, but it's relatively new for people, and I think education needs to be improved in that area. In addition, I know a number of healthcare providers who are a little uncomfortable to bring up weight with the patients. There is a stigma associated with obesity, and so there's a tendency, oh, you're having great time in the visit, et cetera. I'm not going to bring that up at this time. We'll hopefully defer it to the next visit or later on.
It's a way of sidestepping the issue. I hear that a lot. I think a reasonable excuse not to bring it up is that they don't have time, because your focus is, you have a 15-minute visit, you've got all these things you want to talk about. And in order to talk about weight and counteract the narrative, you really do need time. So I actually recommend that when physicians identify this, that they schedule a separate visit, 30 minutes, where all you do is talk about the weight management part of it. Let me just point out something here. I'm going to share my screen with you again. This is from
I was just going to ask you to share screen on that life cycle graph. If you would do that next, I have a question for you.
Well, I'm not sure about the life cycle one, but this is a study of the adoption rates for medications that had come out, with new guidelines. And so, Bill, as I mentioned before, these guidelines have been out for, almost a decade, if not longer. This is not new information that I gave you today, but it is new in this context. And so Lou Aroni and his group went back and looked at physician prescribing habits when the obesity guidelines came out and said, you can use these obesity medications, they're safe and effective for long-term use. Or you could, when the new guidelines came out for the diabetes management, incorporating SGLT2 inhibitors. So they came out about the same time. And what you can see is when physicians were presented with information about incorporating SGLT2 inhibitors into the diabetes management therapies, there was about an 80% adoption rate. It was a very high uptake. But when the obesity guidelines came out, about 1% of physicians started prescribing them. And there's a lot of reasons for that. There's a lot of misinformation that these are unhealthy, they're dangerous, they're bad for the heart, all the things I tried to dispel today. There's also, I think, you talked about implicit bias against obesity. There's also, I think, an implicit bias within the medical community against obesity management. They don't want to take that step. And I also this is another fascinating piece of data from this study, which was they looked at prescribing habits by region of the country the physicians were in. So if you were in the South, you had a pretty high adoption rate of phentermine or the newer at that time anti-obesity medications, about 50%. If you practice medicine, however, up here in the Pacific Northwest where I'm from, it's 1% adoption rate. This isn't that the patients or that the providers in the Northwest knew something different from those in the South. This is providers in the Northwest, my colleagues saying, I'm not going to do this. And then their peer group saying, well, he didn't do it or she didn't do it, so I'm not going to do it. It's more it's not objective. It's more where you train and who you train under as determines it. So we really have a lot of education to overcome with our colleagues about, helping them to understand, the physiology, helping them understand this is chronic disease, and getting them the information they need so they can start incorporating these practices on a more regular basis. But this is a fascinating thing. Hattie, what did you want me to also do?
You had a slide that showed the change from 1970 to the next slide was 2006 that showed in the middle years and ending at about age 60, showing how people start out skinny and then they get thinner after age 60 again. Yeah, it's about where is that?
Where is that? Sorry.
You just passed by it. It was about 10, yeah.
That slide. So for women who go through menopause, you almost invariably see the body shape change, right?
About the data that I'm familiar with, about 30% of women will put on some weight, and it's what characterizes it, it's very central distribution. So you might have experienced weight gain when you're younger, even during pregnancy. The data is about half of women will go back to their pre-pregnancy weight, but half will stay above it. And 30% of women will cross some BMI metric from normal to overweight to obese, but that doesn't necessarily mean it's central weight gain. The hallmark weight gain of those women, the subset of women who gain weight through menopause, is the central obesity. But Hattie, also, we do have to acknowledge that the aging process is characterized by a small amount of weight gain that involves some fat gain, but also muscle loss and central distribution of weight. So it seems the menopausal transition seems to accelerate that in women at that time frame.
So I thought that one of the recommendations of Noelle Berry-Mers, the cardiologist who leads our women's cardiovascular work group, was excellent in saying that having a conversation with women about their weight doesn't tend to go really well when there's a clear hormonal change that's happening that does feel out of control for women. So her suggestion I thought was fantastic, which is to say, focus the discussion on trading fat for muscle, getting strong, increasing your muscle mass. And I don't know whether you've had any luck with that.
I do both. So identify the need for that we call the sarcopenia of aging, or the muscle loss of aging. So I recommend, not only aerobics, but resistance training and yoga for balance and those sort of things. But in women who are experiencing, I don't want to weight gain, beginning usually so the perimenopausal phase is where most of this starts. And if you wait until you're 1 year without a period, you've probably gone through much of that transition already. which is historically the time when most women are started on, if they're going to talk about it, started on something. So we really do need to be looking earlier than that. The problem is that just replacing estrogen doesn't result by itself in a lot of weight loss, if any, in most women. Rodents, yes. A lot of promise in treating rodents with estrogen in terms of weight management. But that physiology is more resistant to just simple estrogen replacement. You get actually benefits from the estrogen replacement in that age with diabetes risk reduction, which goes to an independent benefit on the estrogen on diabetes. But I definitely hit them with both, Hattie, when they come in and we're talking about that. It's very distressing for women at that age to begin to experience unwanted weight gain when they've been normal weight all their life. But I use the same narrative for them.
Fascinating session today, and the power of genes being and just biological factors that are beyond behavioral control. So important to recognize and not be in the space of shaming people for their weight if they're active and they're eating right. So anyway, loved learning from you today, and thank you for your generosity of time and talents. Albert, thank you for bringing up our slide about our next program, which maybe one that you want to attend with us, Dr. Purnell. We welcome you to be part of our leadership team and be involved with us as often as you would like to be. So we have this special opportunity with the National Vice President for Outcomes of the American Medical Association. He's going to be giving the first hour of presentation, and then we'll be discussing with a variety of our other leaders how to take advantage of this opportunity, because what they're doing in concert with the Centers for Disease Control is support for electronic health records that and processes for controlling the very three metrics that we focus on: LDL 100, blood pressure, and blood sugar. So it'd be really nice if we're able to knit together a collaborative with them to spread our best practices nationally. And it's wonderful to have such an enthusiastic physician leading up this program, working with Janet Wright at CDC. So with that, I'll say, let's all go get some exercise and eat something healthy because I haven't had lunch yet, and I'm sure that's true for many of you.
Thank you very much. It was an honor to join you.
Thank you, Patty. Thank you.
Thank you,
everyone.
everyone. Have a great afternoon.
Thank you.